Hello everyone and welcome to the UAE's biggest ever online pregnancy conference, hosted by King's College Hospital London here in Dubai. My name is Dr. Gauri Ramanathan. I'm a consultant obstetrician and gynecologist and a fetal medicine specialist and the Chief Medical Officer here at King's in the UAE. It makes me so happy to see so many pregnant women and couples who are planning a family to have registered. Believe it or not, we have over 800 people expected to be logging in over the course of these sessions. For those of you who are not familiar with King's in the UAE, we are a 100-bed multi-specialty hospital and we're based in Dubai Hills. We officially opened in March 2019 and we have already welcomed 500 babies to Dubai. We have a particular focus on women's health, with an extremely strong team of UK, US, and European Board Certified obstetricians and gynecologists and fetal medicine specialists. I think for those of us currently pregnant or planning a family, times have never been more uncertain with the COVID outbreak, which is why I am so happy and proud today to see such a stellar lineup of doctors, midwives, and lactation specialists who can reassure you things will be okay, and cover all the topics you want to know about your pregnancy journey, from the initial scans through to the birth choices, postnatal rehab and care, and also what to do if you are a high-risk pregnancy. And I'm going to hand over to Rama, our event coordinator, who will talk briefly about the housekeeping rules to ensure everything runs smoothly, and then we'll get straight into the program. Over to you, Rama.
Thank you, Dr. Gauri, for your lovely introduction, and welcome everyone for our online conference. I will be your host for today. My name is Rama Zadan. During the conference, multiple of our world-class doctors and experts will talk to you about everything concerning pregnancy and planning a family. Please, during the session, if you have any questions, comments, feel free to leave them in the chat box. And the doctor or the expert moderating the session at the time will make sure to answer as many as he or she can. We will start off our conference with Dr. Amitabha Mujumdar, consultant obstetrician and gynecologist, and Associate Chef Medical Officer, who will provide you with an update about COVID-19 and pregnancy. Over to you, Dr. Emmett. Dr. Emmett is putting up his presentation and he will start shortly.
Good morning, everyone. My name is Dr. Amit Majumdar. I'm the head of department here of women's and children. And I'll be talking to you this morning about COVID-19 and pregnancy. I'm sure some of you have already heard me talking on this on the various webinars that King's has hosted in the past. However, this is just a recap of all those things that have happened over the past couple of months, which have been quite busy in certain ways, but also frightening because of the uncertainties involved. And mothers who've been pregnant during these situations obviously had a lot of worries. And I'll go through a few of these things in my few slides. I'm also open to questions, some of which I've already got, and others, please feel free to ask them, and I shall try to answer all of them. Now, the COVID-19 is a new strain of the virus, first detected in Wuhan city in China, as we all know. There are other human coronaviruses which have come in the past, which obviously cause mild to moderate upper respiratory tract illnesses, and the most common of which is the common cold. The first patient reported in the UAE was at the end of January of this year. Now, transmission is very important, and it's important to understand this because there is good evidence globally of human-to-human transmission. However, it's readily isolated from respiratory secretion, feces, and fomites. So there are basically two routes, and that's the reason we need to exercise the rules that we have now. And the first is the directly through the close contact with an infected person, and usually within 2 meters, because that's where the respiratory secretions can enter your eyes, mouth, nose, and airways. And that's where this distancing rule of 2 meters come from. Now, the risk will increase if you're, and it depends on the length of time you're in close contact with this infected person. The second is, and more importantly, touching surfaces, objects, etc. And that's the reason the hand hygiene comes into play. So the more you wash your hands and do not take hands where you have put your hands on surfaces back to your nose, mouth, ears, and eyes is the most important thing. And that's where hand washing, and later on as the pandemic developed, the idea of wearing masks came into. Now in pregnancy, does that increase the risk? Now pregnancy, there's good evidence now to suggest that pregnant women do not appear or more likely to contract the infection than the general population. And then with regard to vertical transmission, that is transmission from the woman to her baby antenatally, there is some evidence of IgM transmission. Now, IgM is a acute phase immunoglobulin which does not cross the placenta. Hence, perhaps this represents a neonatal immune response to the infection. In the UK, about 2.5% of babies had a positive swab within 12 hours. And then previous case reports from China did not suggest evidence of any virus in the amniotic fluid, cords, throat swabs, placenta, etc., which is actually good, which suggests that it is not transmitted via any of these routes. Now, we all know that pregnancy itself is an immunocompromised state, but does that mean pregnant women are more susceptible? Could be, and particularly towards the end of pregnancy, not generally. But the general feeling, and this is based on a large study of almost 17,000 individuals in the UK with COVID-19, and it doesn't show that pregnant women are more at risk than the general population of getting the virus in their system. However, because universal testing is not possible in the Western world, hence, or in most countries of the Western world, there is a belief or evolving evidence that there might be a cohort of asymptomatic individuals who might be carrying the virus. And that's based on studies over a 2-week period that was done, and it was found that probably up to 15% might test positive. However, most of these were asymptomatic, and will experience only mild or moderate, which lends credence to the fact that pregnant women are no further at risk than the general population of contracting the virus. What's the effect on the fetus and neonate? Currently, there are no increased risk of miscarriage or early pregnancy loss. If at all, there is no evidence that the virus causes any congenital abnormalities in the baby. There might be some recent suggestion that there might be vertical transmission, although the effect on the pregnancy itself and to the significance to the baby is yet to be determined. And this was done in a small study review of 71 babies born, that within 48 hours, only less than 6% tested positive. So that brings us back to how we look after women with this problem. And it's mostly to do with the antenatal care. And women should continue to have their antenatal care. At the peak of the pandemic at King's College Hospital, we offered teleconsultation, which a lot of you have taken up. We offered home visits. Some of you did take that up. However, I would like to stress that ultrasound scan appointments can only be done in the hospital. Blood test, blood pressure, urine examinations, we can still take to your home. However, the ultrasound scan appointments has to be done. Why is antenatal care important? Because there is good evidence to suggest that women who miss antenatal care have more adverse outcomes in terms of stillbirth, neonatal death, and poorer outcomes for mother and babies. And hence, it's very important to continue with antenatal care. Now, for women who have recovered from COVID-19, you should straight go back to your routine antenatal care. If you have missed appointments, please see your obstetrician, your doctor, as soon as possible. If you've had serious illness, then you should have a growth scan immediately as soon as you come out of your isolation period. For labor and delivery, we encourage those who are either symptomatic, mild symptoms, or carriers have tested positive to be isolating yourself. We do not recommend a water birth because of the risk of disease transmission through feces. However, people who are not positive or not symptomatic, the guidelines are changing, and currently for negative mothers, this is a possibility, and we are opening up water births very soon in our hospital. If there are any symptomatic or confirmed or suspected COVID-19 patients, you will be offered fetal monitoring during labor. You'll be seen by a very senior clinician, and you will have certain observations done during labor and delivery. For recovered women, there will be no changes to labor and delivery during this time because there won't be any changes. And I will take questions because I've got a few questions coming, which I'll take later on this topic. Regarding husbands, birth partners, if you are not positive, it's the same. You are allowed to come. However, if you are positive or symptomatic, you will be screened. If you're positive, you'll be asked to go back home and go through your period of self-isolation. A little bit about breastfeeding. I'm sure this will come up later on in the talks, that there is no evidence that the virus is excreted in the missed milk. Hence, the benefits of breastfeeding should be weighed against the risks. The general principles of hand hygiene, social distancing, etc. still remains. I'll briefly touch on King's experience with COVID. We had 4 COVID positive women who delivered here. Another 3 who were positive and negative now are currently pregnant. 2 of them delivered vaginally. 1 delivered by cesarean section electively due to non-COVID reason. Another was an emergency section, but this was more due to obstetric reasons after being in labor for a little while. The outpatient clinics on the 3rd floor of King's College Hospital is absolutely COVID-free, as is the inpatient labor ward, postnatal and antenatal wards. I'd like to assure you here that there are separate laboring areas for COVID moms, separate access, and the antenatal and postnatal care that we provide is taken to the mom rather than the mother coming. Thank you very much. I've got a few questions which I'll take, which I've already got. So there is one question here. For women with C-section delivery, do we need to be tested for COVID first before being admitted to the hospital? If it is an elective case, for all elective surgeries, we've been asked by the Dubai Health Authority to test everybody. So yes, that is a yes. However, if you do come in, we will go through the symptom questionnaire, and if that is negative, then there's no testing done. When do you test pregnant moms who are expecting during labor? No, we wouldn't normally test pregnant moms, and the reason is current guidance suggests that the testing will be done only on symptomatic patients, or if you're in close contact. And there are very strict guidance for testing, and we follow guidance from the Dubai Health Authority regarding this. There's a very interesting question. How far are we in finding a permanent solution for this condition? I would love to answer this question. However, research is developing very, very fast. There are a lot of things coming out. So hopefully there might be a vaccine, although the number of infections are reducing, and whether we'll be able to test this vaccine remains a probability. But really, the answer to that question is very difficult. I hope I knew that. There's one question. What about if we have family members living in the same house who tested positive but are negative now? I think you should talk to your obstetrician. We'll be able to give you, I think we're running out of time now. Can you I'll answer all those questions in the chat box later on. Thank you very much.
Thank you very much, Dr. Amit. For everyone who asked us questions, we have a 30-minute Q&A chat room later in the session. So Dr. Amit can join and answer all of your questions. Now we will move back to Dr. Gauri, who will talk to you about pregnancy scans. Over to you, Dr. Gauri.
Thank you very much, Rahma. Let me just share my screen. I hope you'll be able to see my screen.
Yes, we can.
Okay, so I'm going to talk about pregnancy scans and what you essentially need to know about it. A few words about King's. Professor Kypros Nikolaides, who's the image that you see in the middle, he's the father of fetal medicine. He has a huge centre, and it's part of King's College Hospital in London. Myself and my colleague, we've had the honour of working with him, and it's a wonderful ability to bring that now into Dubai. Very quickly on the scans, so these are words that you'll probably hear throughout your pregnancy. A viability scan, the nuchal scan, and anomaly scan. I'll go through each one of this so that we have a bit of an idea of what each and all of them are. Let's start with the viability scan. So you find out you're pregnant, you test you're positive, and what we call viability is to look at the fetus to see whether the baby is alive and progressing well. Usually done about 6 to 10 weeks. Generally done abdominally, however, sometimes we would need to do a vaginal scan, and the reason for the vaginal scan is the pregnancy is very small, and vaginal scan images are a lot clearer. We need to determine the number of embryos present, whether you're carrying a single baby or multiple pregnancy, and as I said, to make sure that the pregnancy is progressing well. This is particularly so if you're having any pain or if you're having any bleeding, as well as those who have had previous miscarriages or an ectopic pregnancy. Just a few images of what you would be looking at. Pictures of a normal pregnancy, a multiple pregnancy, and an ectopic pregnancy on the right, which is where the uterus is empty and the pregnancy is lying outside the uterus. The nuchal scan is carried out between 11 to 13 weeks. It's again usually done abdominally. A few reasons we do the nuchal scan. It's not just the nuchal translucency, but the first is to date the pregnancy accurately. Now, women sometimes have irregular periods, get pregnant soon after breastfeeding or stopping the pill. That makes the conception date quite unreliable. And so we measure the size of the fetus from the top, the crown, to the bottom, the rump length. And that's when we give you the expected date of delivery. As I said, multiple pregnancies can happen. The most important thing in multiple pregnancies is to see whether this is a identical or non-identical twin, and in particular looking at the placenta, whether the baby shares one placenta or whether there's two placentas. At this very early stage, there are quite a few abnormalities that we can detect. Now, remember, the main abnormality scan is at 20 to 24 weeks. However, we can diagnose quite a few major abnormalities at this stage. 2% of women who attend for a nuchal scan will unfortunately have had a miscarriage. And sometimes this doesn't show with any findings or symptoms in yourself. And finally, to talk about the nuchal translucency itself. So this is the risk. So in pregnancy, you've got the first trimester scan is really about assessing risk for chromosomes or genetics. Down syndrome being the commonest chromosomal abnormality we see. There are a huge number of ways that we can try and diagnose this, and nuchal translucency is a very, very good screening method. The measurement is of the neck of the baby, and it's measured, plugged into a computer software, and given a risk. And that risk is based on your age. So as you know, the older we get, the higher the risk we have of having Down's babies, based on the nuchal translucency, based on the nasal bone presence, as well as two hormones that we measure, which is beta-HCG and PAP-A. That is all put together. You will have a composite risk, as is shown on this screen, starting with your background risk, and then we adjust that risk accordingly. Now, the two things extra to talk about with Down syndrome, I'm sure you've heard of a Harmony test or the non-invasive prenatal testing. This is when we draw blood from the mother, and we look at fetal cells within the mother's blood. Very accurate, so 99% accurate. The diagnostic test, or the 100% if you like, is a invasive test or a CVS called chorionic villus sampling. That carries a risk of miscarriage, so that's just the last resort, if you like. Moving on now to the anomaly scan. This is the detail scan. So first trimester chromosome genetic screening, second trimester 20 to 24 weeks is when we look at the structure. Has the baby developed normally? This is a scan where we look at all fetal body parts. So from the head, we look at structures within the brain. We look at the face to make sure there's no cleft lip. We look at the spine, the heart, stomach, bowel, kidneys, as well as the limbs. We also look at the placenta. So the placenta implants or attaches somewhere. Sometimes it's low, sometimes it's not. We determine where the placenta is. We look at the fluid around the baby, and we measure the growth of the baby. These are just some images of things that we can detect on ultrasound in the second trimester, particularly of abnormalities that are commonly seen. Sometimes you need a particular scan called a fetal echo or cardiac scan. Now, this is particularly so if you've had a family history of a congenital heart abnormality, if you are a diabetic. Diabetic women have a higher risk. I'm talking about not gestational diabetes, but I'm talking about pre-existing diabetes. if you're taking certain medication for epilepsy, and if you had a routine scan and the person who did your scan suspected that the heart was not clearly visualized. The nuchal translucency, actually, if it's increased, does increase your risk for a cardiac abnormality. So if you had an increased nuchal, it would be suggested to have a cardiac scan. At King's, we have a fetal cardiologist, pediatric cardiologist, who specializes in fetal echoes. Cervical scans are basically to measure the length of the cervix. It is an internal scan, and it's recommended for women at high risk of preterm birth, particularly if you're having multiple pregnancies, if you've had a previous baby that was delivered early, if you've got abnormalities within your uterus, like a bicornuate uterus, and if you've had previous surgery on your cervix for conditions that are local to the cervix. Usually carried out at the time of the anomaly scan. However, if you've had a previous preterm baby, we start doing serial measuring of the cervix from 16 weeks. Finally, the well-being scan. This is a scan done in the 3rd trimester of pregnancy, particularly if you have certain complications in pregnancy, such as preeclampsia, if there's a suspicion that the baby's not growing very well, if there is diabetes, either gestational or pre-existing, if you've had a previous stillbirth. The aim really is to look at the size of the baby, to calculate the weight, estimated weight of the baby, to examine the baby, the movements within the baby, looking at the placenta again, making sure the position is correct and the appearance is normal, assessing the amniotic fluid, as well as looking at the blood flow. Now, the blood flow is the flow that goes from the placenta to the baby, and that is basically looking at how much blood, oxygen, nutrition is getting to the baby at that time. Just certain images, so the biometry or the weight is calculated based on 3 measurements: the head, the femur or the leg bone, and the abdomen. We look at the placenta, we look at the fluid, and we look at the Dopplers as well. A very brief word on 3D, 4D scans. These are external parts of the baby. It's a wonderful way to bond with your baby. You can look at the face, the shape of the mouth, the nose. The baby exhibits certain behavior. Diagnostically, it's certainly good for conditions that are superficial, such as the cleft lip or spina bifida. 3D, 4D scans are very much determined by the position of the baby and how the baby is at that time. So sometimes it's very successful, sometimes it's not. So summary, a list of scans. The 2 main ones are the nuchal scan at 12 weeks and the anomaly scan at about 22 weeks, as well as the other scans that we can offer you. So that is my presentation. Let me try and get to chat. So I've got a few questions here. The cyst in the brain at 20 weeks, but no other markers, anything to worry about? So cysts in the brain are common. It's called choroid plexus cyst. We see it, it's basically when the choroid plexus, which is what's producing the fluid around the baby in the brain, becomes overactive. Doesn't mean anything, does not have any impact on intelligence or mental capacity, and generally actually disappears by about 24, 26 weeks. So make sure you have a follow-up scan on the cyst that was seen. I am pregnant 21 weeks, my placenta is in front and I cannot feel the baby moving. Absolutely, that is the reason. So movements are not are felt from about that time, but not reliable early on. It's only until about 28 weeks onwards where we talk about fetal movements, and we need you to monitor that. The placenta being in front certainly does make a difference in how you perceive and feel it. I had preeclampsia in the first pregnancy. How likely is it to come back again? Yes, you are at a higher risk of having preeclampsia again, Hina. You can have screening tests done to look at your risk. And if you are found to be at higher risk, and this is by measuring a particular blood flow in your vessel called the uterine artery, aspirin is something that does reduce the incidence of it happening again. What weeks do nuchal translucency, when does it done? It's between 11 weeks and 13 plus 6 weeks. Ideal time is about 12 to 13 weeks. When is it better to do a 3D and 4D scan? Best time to do this is at about 32 to 34, 28 to 32 weeks. That's the best time to do it. Sometimes you get good 3D, 4Ds earlier and sometimes later, but as the baby gets bigger, there's a lot more in front of the face, and getting a good image is difficult. When does the risk of miscarriage go away? So the commonest reason of women miscarrying early in pregnancy is because it was a wrong pregnancy. So there was a chromosomal, genetic, and it's nature's way of dealing with it. So once you get to your nuchal scan at 12 weeks and everything is fine, the risk drops down significantly. So yeah, there's a lot more to say about that, but miscarriage is a whole topic altogether. When do I do a harmony test? You can do a harmony test as early as 10 weeks, and really there's no upper limit to when you can do it. Obviously, if you're doing a test, you want to know sooner rather than later, so you would try and get it done as early as possible, but from 10 weeks onwards. I have fibroids with my pregnancy. Will it have an impact on my baby? The largest is on my cervix, right? So fibroids generally don't complicate pregnancies per se and baby's development unless they're located within and impacting within the actual uterine cavity, which is rare. A fibroid on the cervix or close to the cervix may have an impact later on in terms of whether the baby's head can get down, and you might end up with the baby not being in head down position and hence a slightly higher risk of a cesarean section. Another fibroid question. I have a 20 centimeter, I'm assuming that's 20 centimeter fibroid on the top of the root of the uterus. Very unlikely to cause any problems. The only thing with fibroids is sometimes it can bleed inside the fibroids, and it can cause you pain. Now, most of the time, paracetamol, as you know, is completely safe in pregnancy, but sometimes it gets really quite uncomfortable and you may need to come into the hospital for stronger painkillers. But that's all we do. We don't do anything other than treat the symptoms at that time. Let me look at other cords questions. There's a cord question here.
Excuse me, Dr. Gari.
Yes,
so sorry.
Roma.
What I will do is we have received many questions, so
Yes.
I will leave them to the chat room later in the session.
Perfect.
So we can answer all of them. And now we need to move on to our next talk with Dr. Braithwaite. She's a consultant obstetrician and gynecologist and will talk to you about birth choices. Over to you, Dr. Braithwaite.
Yes. Good morning, everybody. As I've already been introduced, my name is Dr. Omolmi Braithwaite, and I am a consultant obstetrician gynecologist here at King's College Hospital in Dubai Hills. I've been asked to talk about birth options, vaginal, cesarean, and water birth. And obviously, in the time that I've been given, it's unlikely that I would be able to go through everything. But I do welcome questions, which I will be in the chat rooms. Most people are aware of the different ways in which people can deliver. However, I think it's important that we go back before we go forward. And I'm one who enjoys looking at the history of a lot of things. And I looked briefly at the part of cesarean births. Where did it start? How far back? And how far we've come along. And it was interesting to know that a lot of this was actually mentioned in Greek methodology rather. And apparently Apollo removed Asclepius, I hope I'm saying that properly, who was the founder of religious medicine from his mother's womb by cesarean section. And of course, with other cultures and different parts of the world, there have been numerous references in as far back as ancient Hindu, Egyptian, Grecian, Roman, Chinese cultures. Presently, in our modern day life, cesarean section forms a significant part of our day-to-day obstetric workload, and increasingly so, as you will see from my next slide, where looking across globally in different parts of the world, and this is just over the last 15 years, from 2000 to 2015, we can see that there has been an increase in the number of cesarean sections that are being done worldwide. Most of it seems to be in Latin America and the Caribbean. There are obviously numerous reasons for this, which I'm sure will come out in the question and answer part of the conference, but most of it is usually as a result of people having had a previous cesarean section and then ultimately going on to have further cesarean section, especially if the first one was for a medical reason. So this has increased our cesarean section rates. Globally, the slide says 21.1%, but I think a more up-to-date value would be in the region of 25%. Now, I will talk briefly about the history of water birth. And even though many people will think that laboring in water for pregnant women is a relatively new thing, and this is not so, because many legends, especially with South Pacific Islanders and Egyptian pharaohs, were born in water. And presently, even in certain areas of South America, women still go to a special place to give birth in water. Moving closer to Europe, you'd find that the first water birth known was in 1805 in France. But in 1960, a Russian water birth pioneer, Igor Tajovsky, experimented with delivering in cold water. And the main reason being that he felt that the cold was neuroprotective for the babies. It protects their brains. About 10 years later on, some midwives and doctors in France were actually interested in making a way and helping babies make a transition from life in the womb to life outside as smoothly as possible by using warm water. And it then became increasingly popularized by the French obstetrician Michael O'Dent in 1983. And the number of water births have subsequently increased over the years. Now, I don't really need to talk about the history of vaginal birth because I believe that has been with us ever since man began, I would say, probably from the time of Adam and Eve. We all know what it entails and how it happens. However, in order to kind of kickstart the questions on this, I thought long and hard about what would really interest our audience out there. And I looked at the pros and cons of having a vaginal birth. Now, the pros are, one, shorter stay in hospital and recovery time. And for those of us who've worked in Western areas, we know that in the UK, with the NHS, you can even go home as early as 6 hours after your delivery. However, the caveat is that there is a lot of support out in the community, and often mothers are visited on a daily basis after they deliver. But that is one of the major advantages of having an uncomplicated vaginal birth. The second point I've highlighted is the avoidance of major surgery. And of course, major surgery can sometimes become complicated. There is bleeding, there is scarring of abdominal contents such as adhesions, especially more in the long term. You can also have wound infection. There's the reaction to anesthesia. And of course, you will need to use painkillers for a longer period of time than if you've had an uncomplicated vaginal birth. The other aspect is the better bonding and holding of the baby post-delivery. And what is quite topical now is having a baby placed onto the mother's abdomen where the baby can root naturally to the breast, and having a delayed period of cord clamping where we would have to wait for the cord to stop pulsating before we actually cut the cord. This obviously helps with the initiation of breastfeeding whilst all this is going on. Another more recent aspect of vaginal birth is that the baby gets a good dose of good bacteria while going through the birth canal, which has been shown to help towards gut immunity. Now, what are the cons against vaginal birth? Well, vaginal trauma, and this can be extensive, and in some cases the patient may need to be taken to theatre to have pelvic floor repair, especially in stages where you can have a 3rd to 4th degree vaginal trauma. For a small percentage of patients, you can get weakness of pelvic floor muscles resulting in urinary and bowel incontinence, especially when there's additional strain to that part of the body. Some patients do get lingering pain in the perineum, which can be very troublesome for them. In some cases, some of the babies can be very large, and we do get unexpected difficulty with the delivery of the baby, which can again result in trauma to the baby as well as to the mother. The last point that I will discuss here briefly is the fact that not all labors are 6 hours and the baby pops out. Sometimes they can be long, they can be painful, and they can be psychologically and grueling as well. Now, the pros and cons of cesarean section. The pro is the major thing that most people go in for, is that it is a good option for a safe delivery. It's planned, it's short, and it's predictable. Now, what are the cons? A longer stay in hospital, risk of wound infection, adhesions and injury to adjacent organs. There's a risk of clot formation, and women are less likely to begin early breastfeeding, and women are 3 times more likely to die from a cesarean section than a vaginal birth. Now, moving on to an aspect of birth delivery that I personally am getting a lot of inquiries about, and which is very popular with women. And during my research for this talk, I can understand why. Now, there is a lower pain score and need for analgesia. The labors are usually shorter in patients who have water birth. There's an increased rate of normal, uncomplicated vaginal birth. There's less trauma to the perineum and greater satisfaction of birth from the mothers. It's been shown that there's been no difference in NICU and admissions when compared to land birth. And there's been no real difference in the outcome of the babies after they've been born. The cons, because this is still fairly new when compared to how long we've been doing cesarean sections and vaginal births on a bigger and longer level, we still need to do more research on the potential risk for vaginal birth. What we must also know is that in order to agree to a water birth in mothers, they have to be as normal as possible. So we will not encourage any mother who has even the smallest of risks to attempt to have vaginal births. So therefore, we're already dealing with a biased population, and you could almost predict your outcome that it will be, in most cases, successful, otherwise you will not attempt it. Having said that, not all water births are successful, and some mothers will opt to just use the water for pain relief and leave when it's too painful to get on a normal couch and have a traditional vaginal birth. There's also been a couple of case reports about babies being infected from an infected water, hence the reason why special care has to be made to make sure that the environment is clean, the temperature in the water is maintained throughout the laboring and delivery process. So my conclusion is that there is no absolute size that fits all. And therefore, the best delivery option for every woman has to be on a case-by-case decision. There has to be an approach whereby the obstetrician as well as the patient have a long discussion about what would be the best decision for a happy baby and a happy mother.
We will move to our next topic around the pain relief options for labor, and Dr. Sonali Nair, she is our specialist anesthesiologist, and she will talk to you about this topic more. Over to you, Dr. Sonali.
So when it comes to pain relief in labor, I think before we discuss the options and what best suits you, what option suits you, we need to understand briefly about what labor pain is, what causes labor pains, how do we minimize the perception of pain, why it is important to do that, and how and when do we plan management of labor pain. Is there any sort of an ideal labor pain relief method? And finally, we will be focusing on what options are available and how does one choose an appropriate option tailored to suit one's requirement in labor. Lastly, we will end the talk with epidural analgesia and the advantages and disadvantages of this method. And finally, if we have time, we could take some questions from you as well. Okay, so as an anesthetist, I do feel that one of my most important and rewarding aspect in my job is to ensure that every woman is comfortable and pain-free during childbirth and labor. Every woman's clinical team should ensure that she has a positive, fulfilling experience of childbirth and has happy memories to take back. When I talk about a clinical team during pain in labor, I would essentially include
Doctor, I'm so sorry to interrupt you, but some of the people watching are telling us that your voice is not very clear.
Okay.
So if you can just come closer maybe and raise the volume or
Okay.
something. Yeah.
Is that better now?
Yes.
Okay. All right.
Thank you so
So
much.
thank you. All right. So now I was talking about the team aspect of pain relief in labor. So when I talk about team, we include the mother as well as her partner. We also include the obstetrician and her midwife, who play an important role, and of course the anesthetist. So this team should together ensure that pain relief is administered in a safe manner, and the mom is comfortable and pain-free during labor as well as childbirth. So how can we describe labor pain? I'm sure everybody knows that it is generally spoken about as being the worst pain one could ever experience. It can be compared to equivalent of being having a digit amputated or 20 bones crushed, scary definitions, but the reality cannot be far away. So it is important that the mother is mentally prepared for this, is aware about it, and she is educated about it. What causes labor pain? So the pain basically arises from the contractions of the uterus and the muscles surrounding the uterus in the pelvic floor. It is caused by the pain arising from pressure, the intense pressure of the presenting part, which is usually the head, on the perineum, on the bladder, on the bowel. So all these pain sensations are then carried by the nerves to the spinal cord, and from the spinal cord to the brain. The brain then sends down signals to the rest of the body to help the body cope with this stress. It is very important for us to manage the pain in an appropriate way, because having a mother who is tired, exhausted, hysterical, and who cannot then make good decisions regarding her pain management and be an active participant of her labor is not a very positive outcome. So it is better that pain is managed early, and all this stress response in the body caused by the signals sent down by the brain to the body to cope with pain can be controlled appropriately at an appropriate time. So, because if this is not done, then sometimes in some mothers, the pain can be excruciating, and the stress response can then cause adverse effects on the baby because of reduction in the blood supply to the uterus and the placenta. So that is why it is quite important to control the labor pain. So what are the options available to us? Ideally, the best option would be something which is easy to administer, where the mother is in full control. There are no side effects for the mom or the baby, and also where the pain relief can be stopped as and when needed, as soon as the requirement is over. We are not far away from the ideal method. Thankfully, modern medicine has made it possible for us to administer adequate pain relief to the mom at any stage in labor, whenever she decides to have it in a safe manner with minimal side effects to the mother as well as the baby. The two broad options available are the pharmacological options and the non-pharmacological options. When I talk about pharmacological options, I mean the medications. So we will be focusing a bit more on the medications that can be given during labor to reduce the pain. We will also briefly talk about the non-pharmacological aspects of pain relief. So coming to the non-pharmacological aspects of pain relief methods, these basically act at the level of the brain. They do not actually diminish the pain or take away the sensations of the pain, but they change the way in which the body manages the pain or the brain manages the pain. So what happens is that it helps you to focus on sensations apart from the pain, on positive sensations or on different sensations like temperature and breathing, etc. So the most important aspect in non-pharmacological management of pain is being educated and aware about the pain itself. Most of the perception of pain can be increased most of the time due to the fear of pain itself, due to being inadequately informed about what to expect, due to the inability of the mom to have confidence that she can go through the process of labor and childbirth and that she can cope with the pain. And also pain can be magnified by lack of support. So it is important that the mother has adequate support during labor. It can be in form of a midwife, in form of a doula, and of course her partner if he's around throughout her labor. That can be very helpful indeed. So the non-pharmacological methods like massages, water bath, breathing, certain positions, and also, escaping into a virtual world, like you can see this lady doing over here, are quite helpful. I would talk a bit more about adopting TENS and acupuncture. So in acupuncture, it's based on the principle that it's caused by imbalance of pain, and negative sensations are caused by imbalance of energies, and acupuncture, that is pressure over certain areas, can reduce this negativity and generate positive energy by balancing these energies. It can help in early stages of labor or in latent phase of labor. Coming to TENS, what exactly happens is that certain electrodes are placed over the pain-carrying nerves of the body, and which is in early labor over the upper back, and in late labor over the lower back. And this is controlled by the mother, and we can then either give electric currents, small electric currents are given in stimulations are given throughout the labor or whenever the mom requests for it. And these sensations then release chemicals called as endorphins, which are the happy chemicals in the spinal cord. And then they cause a sensation of well-being and euphoria and diminish the pain sensations. So non-pharmacological aspects, the mom can, be aware of it and opt for these options in early labor. Coming to the pharmacological aspects of or options for labor, we have the traditional Entonox or gas and oxygen, various medications which can be given during labor, and the golden standard for pain relief, that is epidural or spinal analgesia during labor. So Entonox is nothing but a mixture of oxygen and nitrous oxide, which is administered to the mother through a mouthpiece, and which is then connected to a supply of gas. The mother breathes in during the contraction. This is the advantage of this technique being that it is the action is immediate. It starts to work in 20 to 30 seconds and lasts maximum effect is in about 45 seconds. As soon as the contraction wears off, the mom can stop using it, and the next time she uses it is during the next contraction. So it is easily administered. It does not accumulate too much in the body, and therefore there are not much side effects on the baby. But it can cause nausea, vomiting, drowsiness. Sometimes the mom tends to hyperventilate or overuse the Entonox, which can cause some degree of hysteria in the mother. And it does not really take away all the pain. Coming to the next option, it is of medications. These medications can be simple medications like paracetamol, or we could also opt for opioids. Opioids are broadly what is used in labor is morphine. Betadine used to be used, but largely because of its side effects, we're not using that anymore. At King's, we're using morphine. We are using intravenous fentanyl and remifentanil, which is another option for opioids. The main advantage of opioids is that it can be quite effective even in advanced pain as compared to the other options that we've spoken to so far. Some opioids can be given intramuscularly, like morphine, and some need to be given intravenously, like fentanyl and remifentanil. The advantages of opioids is that it starts to work in about, depending on what you choose, maximum action and peak action can be achieved in about 30 to 40 minutes, and earlier in the intravenous group of opioids. But the disadvantages are that some of them, some amount of this medication can cross over to the baby, as a result of which sometimes babies can be tired, they can be less alert when born, and there could be some neurobehavioral changes in the baby, like difficulty in latching on during breastfeeding, especially if the opioids are given at a time which is very close to delivery of the baby. The next option for pain relief, which again falls in the category of pharmacological options, is the neuraxial block or the epidural analgesia. Epidural analgesia or spinal analgesia is the most effective method for pain relief during labor. And here, a local anesthetic medication is placed in the space either around the spinal cord, as in spinal method, or in the space which is slightly away from the spinal cord, a space called as an epidural space, whereby these medications then numb the nerves, and the nerves are unable to carry the pain sensations back to the spinal cord and then to the brain. As a result of which,
Doctor, sorry to interrupt you again, but again the voice is not very clear. If you can raise your voice, please.
All right. Yeah.
And we just have 1 more minute, and then we will need to wrap up to our next talk. Thank you.
Sure. Yeah. So it is then, is the voice better now? All right. So,
yes, it is good.
Right. So that is what we do in the epidural analgesia. Spinal is short-acting, and it is generally opted for in late labor when delivery is imminent in an hour or so. And epidural is longer-lasting, and it is a continuous process where medications are given through the catheter. There are some disadvantages to an epidural or spinal method, is that it's more invasive and requires more monitoring. And also there are some contraindications, like if you have a bleeding disorder or there is a source of infection, we may not be able to do that for the patient. And the side effects, though rare, some of them can be worrying, like any kind of nerve damage. But again, that's very rare, with a chance of 1 in 100,000. So this is what exactly happens in an epidural. This is a process of epidural. And there are some facts that I would like to clarify. Take this opportunity, and please, I would like to give this message that epidurals do not really cause a backache. They do not increase the first duration of labor, and do not increase the rate of cesarean section. They do not adversely affect the baby as compared to other medications or other options, pharmacological options. They may cause heaviness of legs, may increase the duration of second stage of labor, because of which there may be a need for instrumental delivery. So I do hope that after this talk, I have been able to give you this message to take home, that modern medicine has indeed made it possible for a woman to have a comfortable and relatively pain-free labor. If a woman chooses to have a pain relief in labor at any stage, her clinical team should ensure that she's empowered to make an informed choice about what option is most appropriate for her, because each woman is unique and her expectations and her beliefs and her requirements are different. So I would like then to finally thank all of you for joining us today, and apology if my voice was fading away during the talk. I look forward to your questions in the question and answer session later during the day. Thank you.
Thank you so much, Dr. Sonali. And I would like to also mention we are receiving some questions on the Q&A during this session. So if you have any question, leave them there. And our doctors are typing in the answers as well. Now we are moving to our next session with Dr. Samina Dorner. She is a obstetrician and gynecologist consultant, and she has a subspecialty in maternal fetal medicine. She will talk to you about high-risk pregnancies. Over to you, Dr. Samina.
Hello, good morning, everyone. Hi, there is or almost good noon. So I have no fancy slides, you know, and I just thought I'm going to just speak to you, and most of the time I probably will just answer your questions. People often say, I mean, my topic is high-risk pregnancies, but we will touch on a few things. But before that, can I just say, on behalf of Kings, thank you so much for joining. Those who of you are first-time parents or parents-to-be, I mean, these are your last few weeks and months to enjoy your life. And here you are listening to old, boring folks like us. So thank you. You have made our day. And as far as pregnancy is concerned, and people talk about high-risk pregnancies, or sometimes people say, well, you are a low-risk pregnancy. High-risk or low-risk pregnancies are a retrospective diagnosis. When your child is born, has started going to nursery or school, then you look back on that pregnancy and you realize that your pregnancy was low risk. So it is not something which can be easily predicted. Now, in some cases, of course, you know, we would label you as a high-risk pregnancy. So, for example, if you are a first-time mother, because you are an unknown quantity, right? We don't know how your body is going to behave in pregnancy. Or if you have any medical conditions yourself, or you have a strong family history of any medical conditions or obstetric conditions. And then, of course, comes the baby. If there is anything that the baby is, or the fetus, as we should call it, is diagnosed with, whether it's structural abnormalities or whether we feel that there is something more going on, that becomes, of course, a high-risk pregnancy, and depends on what kind of a situation it is. So it requires that kind of a organization of your pregnancy. But at the same time, we should never minimize the mental risks that one is at when you are going through pregnancy and when you deliver and afterwards. So and you know, these are very, very important things that we can talk. So we can just touch on you know, few little things. For example, diabetes keeps coming, you know, into the topic, and my colleague Imran has already spoken about it and in detail, or I think he's going to join you. So I'm going to leave most of it to him. But as far as, you know, diabetes, thyroid abnormality, sometimes people, as Dr. Gowri mentioned, repeated miscarriages, or those who have, as my other colleague Brathwaite mentioned, previous cesarean sections. So all these will come under the umbrella of the high-risk pregnancies. And then there are some other medical conditions, asthmas and various others. Or if you are somebody who is going through a mental situation as well, you know, then the pregnancy becomes very high risk as well. But look, the idea of a high-risk pregnancy does not mean, or if you are a high-risk pregnancy, it doesn't mean that you are not going to get to enjoy it, or you are, you know, doomed in any way. You will enjoy that pregnancy. The whole point of this topic is, the whole point of institutions like King's or multidisciplinary hospitals is that we identify a pregnancy which is of any kind of a risk, and then we involve multiple disciplinary team into that pregnancy. So it's not a one-man show, and it should never be a one-man show, no matter how clever I am or how clever my other colleagues are. These are not things which are managed by one person or should be managed by one person. So the more and the merrier, the more people we involve. So if you are diabetic, the endocrinologist should be definitely involved in your care. If you have any cardiac condition, the cardiologist should be involved. If you have any lupus conditions or other autoimmune diseases, then we would have a internal medicine specialist or rheumatologist who should be involved, and so so on and so forth, all those things. How do we take care of high-risk pregnancy? How does it work? So we have a high-risk pregnancy team in King's, which has a lot of members, everything that I mentioned, and some of the other colleagues. We all work very closely together. So it's not, I am the maternal fetal medicine subspecialist, but it doesn't mean that, I can be there 24/7. So of course my colleagues will be there as well. So we all manage cases together, and that is why you should be aware. Never be afraid when it comes to King that, oh well, if Dr. Dornan is not there or if Dr. Azra is not there, who's going to take care of me? We hand over cases very well to one another, and anyway, all the information is on the computer. So everything about you is available to the obstetric team, or the relevant team, I should say. So whenever you enter the hospital, we open your record and everything is there, the history, what we have done with you so far, what your investigations had been, and then what the management of your pregnancy is. So it doesn't change really just because the person changed, because we would discuss high-risk pregnancies in a multiple disciplinary team. So we do talk about you when you are not there as well. We say, well, for example, Melissa has this condition and I am doing this. Does anyone have any other point, anything which has been missed? Should we be doing something else? So, and that should be very reassuring that, you have been taken care by a expert team. So how do we take care of you? We take care of you if it is a maternal conditions, and then what the maternal condition has effect on the baby. And how do we monitor the fetus then? And then, of course, the delivery comes. How do we deliver you? Does it depend? In some circumstances, yes, but not in all. And then what is about postnatal, and what is the planning for your next pregnancy? Yes. Now, sometimes we are very fortunate that some of you identify yourself as a high risk, and you come to us before you are pregnant, which is fantastic, because then we can really put things in place. For example, those who have had a baby with a previous baby with any anomalies, for example, let's say spina bifida, so we will make sure you are on folic acid at least 3 months before your pregnancy. And by the way, everyone should be on folic acid, even if you're not planning to get pregnant, but you are a fertile woman and in a relationship, please take folic acid, because can I tell you, 90% of the pregnancies are not planned. And not that they are not wanted, but they're just not planned. So these are, these are some important facts. So when it comes to your complication, if you are diabetic already, or you suffer from thyroid disorders or anything, we would then refer you at the very first appointment. We will lay down your management plan, and we will identify who else should be involved in your care. Diabetics, I keep taking this name because it is one of the commonest medical condition in pregnant women, and it is very common in this part of the world because of the genetic predisposition of Asians, South Asians, and Middle Eastern population. Whether it's genetic predisposition, and on the top of that, of course, our wonderful diet, which also puts us at risk, and of course, sometimes the lack of physical activity because of the weather and children and so much responsibilities. So I will take again the diabetic one. the management of the mother is to make sure that she has been given a good dietary information. She's on higher dose of folic acids. She sees the endocrinologist on regular intervals. Her blood glucose are being monitored. And of course, we make sure that she is weighed at every visit. And then we monitor the fetus as well, of course, because the fetus in diabetic mothers, in majority of the time, they can grow quite big, and that can be quite an indication that diabetes is not terribly controlled. But in some diabetic patients, the fetus don't grow, which don't grow big, but actually grow less, which we call growth restriction. That is more worrying for us, and we need to pay more attention. I want to say something, and I want to make sure that the diabetic mother understand that it is never as such their fault. Okay, you can have a very, very strong diet control, but you still your diabetes and your blood sugars might be out of control. So don't be too hard on yourself. These things happen. Placenta produces certain kind of hormones towards the end of the pregnancy where it develops resistance to diabetes, and Imran will talk about it. So these things happen, but we know how to monitor you, we know how to deliver you as well. I want to make sure that you understand that though King's is very much in giving you your birth plan, your birth wishes, but in my professional career and as a high-risk obstetrician, the more you leave things, to, do things as you go along, okay? Because things changes in pregnancy. And then disappointment sets in that, if you had planned to, deliver in certain way or deliver at certain time or, and then you are disappointed in yourself, and you shouldn't, because, there is you, and then there is your obstetrician, and then there is nature, and then there is whatever God you believe in, so not everything is in your control. The idea of the pregnancy is, no matter what kind of a pregnancy, that it is safe. You are safe, your baby is safe, you enjoy the process, you enjoy the birth, and you enjoy the product of all that exercise, the baby, and the baby is safe. So please remember that. Scans in various intervals. My colleague, Dr. Gauri, spoke beautifully about it, and she has mentioned all the important scans. Scans are important at certain stages, and it's important that when we do them, we identify to you what is the scan for. It's not just to reassure you or listen to the fetal heart and things. That's good, all that is also very good, but every scan has a reason why it is performed. Early pregnancy, to make sure it's a viable pregnancy, it's in the right place, it's the right number of the fetuses, or we know, and then we go on. Okay, so listen, let's just address some of the question. So one of the question is coming that I haven't gained much weight during my pregnancy. Does that necessarily mean I will deliver a low birth weight? No, not really. So babies, in the nicest possible way, I want you to remember, babies are like parasites. They will take from you what they need. So don't worry about your weight. Baby will be fine. And some women don't gain a lot of weight. Total weight gain in pregnancy till the end of the pregnancy should not be more than 30 pounds. That's the maximum. So you can understand. So then there is a question that what are the impact on pregnancy and baby if the mother is overweight? Now that is an important question. I do want you, if you are not pregnant and you are getting into pregnancy, to optimize your weight. Okay. Now some are genetically built big. That is okay. That not necessarily means that you are big. It's BMI that we look at. Yes. So that is fine as well. I'm sorry, but I have to bring my baby as well into this because he keeps coming and wants to say hello to all of you. Okay, this is Bo, by the way. So just say hello to Bo, and then I will let him go. Okay, Bo. So it's important that we do that. So we have a dietitian in King's which can advise you. So we will keep an eye, very strong eye on your weight gain, and we will advise you about your diet and exercise. One of the best exercise you can do in pregnancy, please swim. Even if you can't swim, walk in the water. okay, in the sea or wherever, that will give you exercise of all the muscles, everything. Now, then there is a question that first pregnancy was very high risk due to bleeding throughout the pregnancy. Son was born at 30 weeks. Does my second pregnancy have to necessarily be high risk too? Usually the risk is there, but it doesn't mean it's 100%, 50% or 25%, maybe 1% more than the rest of the population. So every pregnancy is different than the previous pregnancy. Okay, I constantly hear from women that, but this pregnancy is so different than the previous one. Yes, of course, because you are that much older, you already have a baby, your body has already gone through, the pregnancy changes. So yes, every pregnancy is different, and hence never consider your pregnancy as completely low risk till you have been through it, till the baby has delivered. Okay, so these are retrospective diagnoses.
Thank you so much, Dr. Samina. So sorry.
So water birth, as you know, at King's, we've been complying quite strictly with regulatory requirements and not putting anybody at any risk. DHA is who we follow in terms of what they allow and what they don't allow. Will water birth be opening again? I think it will be very soon. I cannot tell you exactly when. It's going to depend on what our regulators say. But we're hoping to be able to do that soon once we feel that it's safe to do so. A question on anemia and delivery. Again, I'm answering on behalf of my colleagues who are probably not on yet. I think depends on the level of anemia and depends on your level of hemoglobin. Obviously, it's best to optimize that prior to your delivery. And if we can't, what we do is we try and minimize blood loss at delivery. And if need be, we can, if you recover slower after delivery because of your anemia, there are things that we can do to support that. So the answer is no, it shouldn't impact, but it depends on how low your hemoglobin is.
Is aspirin safe to take during pregnancy, even if you don't usually have high blood pressure?
Okay, so no medication should be taken just for the heck of it, and we feel that, okay, maybe it has no side effects, but maybe it will have some benefits. So your obstetrician should be able to discuss with you, is there any indication in your case for aspirin? First-time mother, overweight mothers, or those who have had previous miscarriages histories, or if you have been seen by maternal fetal medicine or fetal medicine person and they have looked at the blood flow in the arteries which supplies the uterus and there is a high resistance, then you are a person. Or if you have had a previous baby with a growth restriction. So there are reasons why aspirin is given to mothers, or if you had a previous severe preeclampsia and high blood pressure. So discuss it with your obstetrician, but please don't take it just yourself. It doesn't really have a side effects per se, but if you have any other underlying medical condition, it can cause a problem. So it is important your obstetrician knows what medications you are taking, if there is any cross reactions then between drugs. So very important.
All right, the next question is, when should a mom not opt for epidural? So that's for Dr. Sonali.
Thank you for the question, and it is a very valid question, and I've been seeing that question typed again and again. So this is the answer to all the other people who've put forward the question as well. So there are a few contraindications for an epidural. Some of them are absolute contraindications, and some are relative contraindications. So the absolute contraindication for an epidural, I would say, is a coagulopathy, which means that there is some bleeding disorder, underlying disorder, because of which placing an epidural in this particular mother can be dangerous, because when we do an epidural or a spinal, it is an invasive procedure and with a potential to bleed. And if at all there is a tendency for the needle to go towards a blood vessel. There could be bleeding, and if the ability of the patient to create a clot is suboptimal, then the bleeding can continue, and eventually it can cause pressure symptoms either in the spinal space or in the epidural space, which can then lead to further adverse effects like pressure on the nerves, which can cause long-term damage in form of either a loss of sensation or a loss of motor power or loss of bladder or bowel. So that's the reason why we avoid doing spinal or epidural in patients where this bleeding disorder is not corrected to begin with, or on patients who are on blood thinning medications where the tendency for the blood to clot is reduced or the tendency to bleed is increased. So these are two conditions where we avoid putting an epidural. Another contraindication for an epidural, which is absolute, could be a source of infection, which can be generalized, like a generalized sepsis, or a localized source of infection over the area of the skin where we are going to introduce the epidural needle into, because this can then lead to further complications like infection around the spinal cord, leading to meningitis or a chemical reaction, etc. And that's another contraindication for doing an epidural. Other relative contraindications would probably be technical difficulties or the patient who is unable to cooperate for the procedure itself.
Thank you, Doctor. Thank you very much. Another question for Dr. Gari is, when will the third trimester scan be carried out?
So the third trimester scan is usually done at about 32 to 34 weeks. Again, it depends on the indication for the third trimester scan. If it's a routine, yes, 32 to 34 weeks. Obviously, if you've got any high risk, then we change that for you.
Okay, Dr. Brathwaite haven't joined us, but someone is asking about water birth. Water birth has any side effects?
Samina? You're
Dr.
on mute, Samina.
Yeah, you are on mute, Doctor.
Yeah. So, water birth, does it have any side effects? Well, it depends, on your indication. If there has been no complication during your pregnancy, your baby is fine, you are fine, none whatsoever. So yes, there is no side effects, but there are some case studies which has shown infection in babies' cases where they have been born in the water. So laboring in the water is fine, but there has been, and because of that, King's has introduced a very rigorous cleaning techniques to make sure that doesn't happen. But can it be completely avoided? No, it can't be. But saying all that, can a fetal baby infection be avoided during vaginal birth completely? No, it can't be. So things happen. And but mostly it is very safe, in a safe hands, and we have very well trained midwives in King's who run this like a military process. So it's quite safe.
Doctors, I have many questions coming in to the chat. So would you help me answer, like typing in some answers to the questions we're receiving to the Q&A? And I will be navigating on the chat box and refer to your name depending on the question. So there's someone asking, what's your thoughts on induction on week 38 to 39?
So I can answer that. In the past, there was a concept that if you are induced, that your risk of a cesarean section increases, your risk of a instrumental delivery like forceps and all that increases. And modern research has shown that that is actually not the case. naturally, induction, why are you being induced? Okay, so if it is for the fetal reason or for the mother reason, for example, if you are diabetic, you are induced at 38 weeks. This is a universal process, because we cannot monitor these babies after a certain time. Diabetes causes biochemical changes which are not possible to be monitored by scans and Dopplers and things. So there is very high risk if we carry on, you are diabetic on insulin or on medication, and so you should be induced at 38 weeks. On a diet, we can take you a little further, but depends how the baby is and everything. So the short answer is a Scottish study came out. If you Google Scottish study and induction of labor, you will see the most up-to-date information on it, and you will see that induction of labor actually reduces the rate of cesarean section and complications to the mother and the baby rather than increasing. So there is now very clear evidence.
Another question. Also, what are the ideal vitamin D levels during pregnancy?
Not my favorite question.
Okay.
I don't believe on taking multivitamins and all that stuff, because I think you should have a balanced diet. Vitamin D deficiency is a very common thing among South Asians, Middle Easterns, and Scandinavians. Ask me why. Because why? Because these are the people who don't expose themselves to sun, and Scandinavians don't have sun. So that is why. So the best solution for a low vitamin D, there are some diseases in which the vitamin Ds are low. These are extreme cases. Let's not talk about those. Generally, you need to expose yourself to sun. That doesn't mean you go and sit in the sun. You can sit in the shade and you will have sun, and your vitamin D level will improve. So, yes, people believe on taking a lot of vitamins. It just gives you an expensive pee, really, an expensive urine. But go ahead, it gives you a psychological satisfaction that you are doing something. So vitamin D dosage is appropriate what your obstetrician is telling you. Just go for that. Trust me.
All right. Mrs. Maha is asking, is it normal for the baby to be head down at 29 weeks?
Yes, of course. Most of the time babies will be head down, almost starting in a third trimester, or even way before that, or even throughout the pregnancy. Remember, as the baby grows bigger, the brain is one organ which keeps growing till they are 28, 29 weeks. And as the brain becomes heavier and heavier, it is a simple nature way of gravitation towards the pelvis, because you are upright, and so the heavier part of the baby just falls into the pelvis. So yes, very much so.
All right. The next question. Is an IVF conception with higher maternal age and PCOS automatically considered a high-risk pregnancy, Dr. Samina?
Yes, these are risk factors. Do we think they are terribly high risk? No, not necessarily, but by definition, in principle, they are considered to be high risk, because these are we are tricking the body into pregnancy right from the beginning, right? We are assisted reproduction, we are helping the body to get pregnant. And so we have manipulated in these cases the nature so much, including the conception, fertilization, even starting from the egg, to stimulate the ovary, collect it, fertilize it, put it in, and then give mother so many medications to make sure that pregnancy is sustained, maintained, and taken to term. So yes, these are very much considered to be high-risk pregnancies. Very much.
It is perfectly safe to have an epidural, whether you have a scoliosis or kyphoscoliosis. Basically, what happens here is that the anatomy of the spine is different. The shape of the spine in this case is different. Therefore, the epidural can be technically challenging to perform. But once it is done, there is no need to worry that it can be unsafe. It can be a difficult procedure, and it may happen that it may not be 100% effective because of a change in the way the spine is in these patients. The medication may not spread adequately to all areas where we wish it would spread, and therefore it may not be 100% effective. However, there is no reason not to have an epidural in these patients. And with modern medicine and use of ultrasound, it has become easier for us to actually visualize where it is most appropriate to put in the epidural needle and subsequently insert the catheter, so that the technical difficulty is also reduced once this ultrasound is used. So I would in fact encourage all patients with these kind of spinal abnormalities to choose for an epidural earlier in labor, because sometimes if they do need additional interventions, it can be difficult to do a very hasty spinal for cesarean section or any other reason later on during emergencies. So yes, it is safe to have an epidural in these patients with spinal abnormalities.
Thank you, Doctor. I'm seeing few questions here regarding topics which will be covered later in the session, including diabetes during pregnancy. That will be covered after the break by Dr. Imran Khan. Is it possible for PCOS to disappear after delivery?
Oh,
Mina.
yeah, may I take that? So
Yes, of course. Please, Doctor.
So PCO, PC is polycystic ovarian syndrome, quite common in this part of the world, quite common among women throughout the world, to be honest, much more than we ever thought before. And especially among Asians, South Asians, and Middle Eastern women. And again, I think it is, yes, genetic, but also very strongly related to our diet and our how we live our lives, lack of exercise and things. But you can be very slim and you can have a polycystic ovarian syndrome. Does it disappear after? Not really. But polycystic ovarian syndrome can display itself in some patients quite strongly in the form of gaining weight and excessive hair growth on the chin and on the chest area, irregularities of the menstruation, and such kind of abnormalities. So, and it is also quite directly related to the weight gain. The more you gain weight, the more the condition can get worse. So be very careful of your weight gain and make sure that you don't do that. So regular exercises reduce your weight and it will be under control. Other than that, if you still have a problem, it depends what kind of a problem you have. Is it infertility? Is it irregular menstruation? Please consult your obstetrician and gynecologist. They'll exactly tell you what you need to do. So, but don't worry if you have it and it's not bothering you, it's fine. It doesn't make you any, at any higher risk. Just weight gain is important to watch. It puts you at higher risk of developing diabetes later in pregnancy.
Okay, another question. If the baby is in a wrong position, is it possible to correct the position for a normal birth, doctor?
Yes, it is called external cephalic version. We turn the baby around. So it depends, if the baby is what we call it breech, upside down, the head is up towards your rib cage and the bum is down in your pelvis. In some cases, it is straightforward case. Majority of the time, the babies will turn themselves by 36, 37, and believe it, even 1% will turn themselves around even at term, when you are 39, 40 weeks. Rare, I have not seen, and I'm sure Gauri will agree, we have not seen much of that. And probably they were already cephalic, but people didn't used to scan in those times, and so that's where the percentages comes from. They can be turned around, but be careful. Sometimes there is an inherent reason why the baby is breech. Either it's the the way the baby is, it's unable to mobilize its hips properly. Usually a dislocated hips in the womb can cause that as well, or sometimes we think that the breech causes that, or it can be your uterus, there can be uterine abnormalities, or it can be where the placenta is lying, maybe too low, it doesn't allow the baby to come head down. So there are many, many reasons. So no, the answer is no, not every pregnancy can be turned around, every baby can be turned around safely. Best to discuss with your obstetrician, but those who are comfortable in it, not all obstetricians are comfortable in turning babies around. So make sure you are seen by those who are or who can openly advise you what is the best thing to do. King's is full of such obstetricians. So
Dr. Samina, a question for you. Is induction necessary in high-risk pregnancies, such as those in blood thinners, high risk for preeclampsia?
Preeclampsia. Okay, so either you have preeclampsia or you don't. So inductions, there are many, many reasons for induction. Remember, we talked about it. Either it's the reason of the mother has the reason, because of her own indigenous diseases, for example, diabetes, and we talked about it, that it is not a good idea if you are diabetic and you are on medication to leave you beyond 38 weeks, okay? It is not a good idea. And it's universally accepted fact, and there is a scientific basis for it. And if you are preeclamptic, that means your blood pressure is high and you are throwing a lot of protein in your urine, which means your kidneys are being affected. It's common sense, isn't it? If you are going through something so severe, which is affecting every organ in your body, you wouldn't want to carry on with that pregnancy, because we can end up in a very disastrous situation. So induction very much is important. And in cases of very severe preeclampsia, you might have to be delivered quite early. 37 weeks, and very severe preeclampsia starts from 24 weeks onwards. In some cases, these women has to be delivered to save their lives and their babies' lives at 32 weeks as well. So it depends on the condition. Induction now is very safe. It doesn't increase the risk of cesarean sections, doesn't increase the risk of instrumental deliveries. I strongly urge parents who are listening to this to Google Scottish study and induction of labor term. And remember, the term is anywhere between 37 weeks to 40 weeks. So it is not one date. Okay.
Thank you very much, Doctor, and thank you everyone for coming into this chat room. The time is out. We need to go back to the conference. If you still have unanswered questions, we have another chat room later in the session, so you can tune into that one. Thank you very much. And we also have moved the virtual tour until the end of the conference around 2:45 due to the load of questions that we received over here. Thank you. I will see you in the conference. With us, Dr. Imran Khan. He is a consultant endocrinologist and will talk to you about diabetes and thyroid in pregnancy. Over to you, Dr. Imran.
Good morning, everyone. Assalamu alaikum. Nice to see you all. Obviously, I can't see you, but I've been given this task to talk about gestational diabetes and thyroid. I have a special interest in antenatal or pregnant women with medical problems. Particularly, the biggest issue that I face is with gestational diabetes. And I'll try to do it within the very short time I have, and tried my best to answer questions. I'll go to my slides and I'll share my screen with you. I've been practicing in UK for about 25 years. I've joined King's and I'm proud to be part of the team. I've been here about 10 months now. I'm working very closely with the obstetric department so that we can give joint care. As myself, as Dr. Samina mentioned, it's not a single person's job. It's a combination, and we discuss cases and we highlight issues to each other and do the best care we can. And every person is different, and it's all about individualized care. So it's not one size fits all. So I have to emphasize that. So what's diabetes in pregnancy? Well, yes, we do have patients with type 1 diabetes. Currently, we've got a few who are delivering and are pregnant. We're looking after. There's a smaller portion of type 2 diabetic who have already been diagnosed and are on treatment. But majority, as you can see from this slide, 88% are gestational diabetes. The incidence in UAE is particularly high. About a third of women have gestational diabetes. So you can see how big a problem it is, and certainly keeps us at King's busy, and we all enjoy the work, and it's giving us a lot of experience, though we all share our experiences with each other. Just a little bit about the technical part of what is it? What are we talking about? So basically, pregnancy is a state of insulin resistance. So just coming to what insulin is, and when we eat any food which is carbohydrate, and doesn't matter whether it's good carbs, bad carbs, low glycemic, end of the day, when the carbs come in, they change into sugar. We call it glucose technically. That then goes into our blood. It needs to go into the cells. To move it into the cells, insulin is the key to push it into the cells, and everything's fine. Now, sometimes the insulin is not efficient enough or not effective enough when we call it insulin resistance, and the insulin is not going into the cells, so some of it is landing up higher in the blood sugar. Now, when it lands up higher in the blood sugar, that then goes to the baby because it does cross the placenta, and the amount of load on the pancreas of the mom goes up about twice as much. And this is not due to the mother eating sugar or carbohydrates or because they've been naughty or anything, but it's just a fact that their placenta and their hormones are increasing their insulin resistance, and they require more insulin, which they're not able to cope with. Usually maybe a genetic predisposition, obesity, and we'll talk about the risk factors. So you can see here the insulin requirement goes up, as you can see in this graph, and tends to happen after 23 weeks. And that's why we tend to do the testing around about that sort of time, because that's the riskiest time. So like I was mentioning, so the blood sugars goes up, the blood sugar passes to the baby, it goes through the placenta, the baby gets more glucose, the pancreas in the baby develops pretty early, so it starts making more insulin. So when the baby gets more glucose from the mother, and its own insulin encourages it to grow bigger than it should, and it starts getting larger in size, which can then lead to complications in delivery because they tend to not deliver normally. Sometimes they may need cesarean sections and forceps if it's not well controlled. However, the goal is that we allow a normal pregnancy, normal vaginal delivery, and we don't need to go into these complications. One of the other complications is when the baby is having high sugars, it has to excrete it in its urine, and that then increases the fluids around the baby within the mother's sac. The baby starts getting more fluid around it because the baby is passing more urine, and that itself adds to the issue. And then there are other risk factors I will talk about also as the consequences of these high sugars. So basically, it's more insulin, more glucose coming to the baby and increasing its size. Who's at risk? Well, the people who are at risk are somebody who's previously has gestational diabetes. Most people here who are non-white, non-Caucasians are at a higher risk. People from the subcontinent in particular, and we have a large population here. And then similarly, people from the Middle East, local population, African population, Hispanic, all of them. And we have a variety of patients here, as we all know. They are at a higher risk. So in Dubai or in the UAE, we're certainly seeing much higher levels of gestational diabetes. Again, as we are as a developing or developed nation, women are working and they're delaying their pregnancies for numerous reasons. We're seeing a lot of ladies with pregnancy over the age of 35. That itself is a risk factor. And a higher BMI, this is body mass index, means how overweight somebody is, puts you at risk. If they have been diagnosed with polycystic ovary syndrome, again, a very common condition I see in my endocrine clinic regularly. It's about a fourth of patients have that. they're at a higher risk. And if there's family history of first-degree relatives, again, being here not too long now in this country, I can see nearly, I wouldn't say everyone, but most patients have a first-degree relative, mother or sister or brother being diabetic. So it puts the risk factors very high. And then acanthosis nigricans, a fancy word for if you have dark black velvety skin around the neck and around the armpits, this also suggests insulin resistance, and we need to watch out. And people need to be screened earlier. Sorry, I heard something, but anyway, I'll carry on. So we do the screening usually at 24 weeks, and those are at high risk. We try to screen them earlier, maybe even at 16 weeks, but the standard is 24 weeks. So this is just a slide saying, you know, the Asian population is about 2.5 or 2 times more at risk. And if your body mass index is BMI is more than 25, you're 3 times or more at risk. And if you've had previous gestational diabetes, you can see you're 13 times more at risk. So the risks are pretty high for these patients. Now, how do we diagnose it? Well, we get a lady to fast for 12 hours. They come in, we take a fasting blood sugar, then we give them a glucose drink, which is not very tasty, I must say. I've tried it once and I wouldn't have it again. But anyway, you take the glucose drink and we test your blood sugar after 1 hour and then after another 2 hours. And if the levels are higher than the numbers you see on the screen, then we diagnose and we say these patients are at risk and start monitoring them very closely. And you can see the different criteria for different countries in question. The risks which I've just mentioned, and I'll quickly go through the mother's risks. The mother itself, there's a risk of miscarriage, infections, increased fluids around the baby, which we've just mentioned. Preeclampsia is also higher in such patients with gestational diabetes. They have high blood pressure, which needs to be managed. They may go into premature labor. The risk of sections are high, though at King's we do our best and very good at doing normal vaginal deliveries and avoiding sections with good care, but it does increase the incidence, and there may be what we call placental insufficiency. And as Samina mentioned, sometimes there's growth retardation rather than big babies, and that can also happen. As far as to the baby, well, there is increased risk of malformation. The main risk which we've talked about is bigger babies and birth trauma. So when they come out, they have difficulty and the shoulder can get stuck and they can get a dislocation of their shoulder. Unfortunately, the incidence of stillbirths increases, and there's something called respiratory distress, lack of oxygen. So the baby needs oxygen when they're born. They may be jaundiced. And their blood sugar may go down, which is strange, but the mother's got high blood sugars, but the baby's born, the sugars fall. And the reason is why I mentioned is the baby's producing more insulin, and the mother's glucose finishes as they're delivered and the placenta is clamped. So their insulin's still high, so they drop their sugars temporarily and they need a glucose drink. So we watch these babies carefully with close supervision from our neonatal team, because we know they're our patients, our babies, so very closely as a multidisciplinary team watch them to give us good results. So here you can see just a picture of large babies, and this is a normal sized baby and a large baby, and the large baby looks healthy, but actually is a challenge for the mother and all of us, and it is at higher risk. This is what I mentioned when they're coming out. Their shoulder gets stuck and they can cause dislocation there. What do we do? Well, once you find out that they have gestational diabetes, we take it very seriously. We don't take it lightly. And I, as an endocrinologist who's got special interest, working very closely with my obstetricians colleague, will see them within days, if not, if within a week. But we try to see them very quickly so that we can give them nutritional advice, and I'll go through with them regarding diet. We have a dietitian, and we will advise them diet, exercise, lower carbohydrates, and I can discuss that in question time, because I'm sure most of the questions may be related to diet. But in general, I'm saying it's a low carbohydrate, more exercise. Important part of this is that we will require, which my poor ladies don't like, is testing their blood sugar from their finger. So we give them a glucometer and they will be testing their blood sugar after every meal. And I see them either once every 2 weeks if they're stable, or once every week depending on what we're doing. And we may offer them either tablets, which are metformin, or insulin, and there are different types of insulin, to make sure that the fasting readings are below 95 and the post meals are under 140 after 1 hour and 120 after 2 hours. And that's essential, and we monitor that very closely. Many times we can, about 75% or so can manage with the diet alone, and we don't need to go on to insulin and tablets. But that needs individualized care, advice, motivation, and support, which well, I'm available. And pregnancy, so if there is obesity, we need to work on that, and it's best that I see them or our team sees them before, so we reduce that risk so they don't develop diabetes or gestational diabetes, and reduce the risk. And this is we spoke earlier, I was listening, somebody asked a question about the weight gain. So it's not necessary to put on weight during pregnancy, but these are the average weight gains. So if somebody is high BMI, and most of my patients are about 30, they would be expected not to increase more than 7 kilograms during their pregnancy. What's the risk, future risk? Well, there's a future risk of the patient developing diabetes in the next 5 years by about 50%. That's me done with my gestational diabetes, and I will just quickly mention about the thyroid, as I was asked to talk about that, and I've still got about 4 or 5 minutes according to my stopwatch, I'm afraid to say. So yes, it's a high risk for women. About 10% will have a problem with their thyroid. The requirement of iodine increases in pregnancy. If they're already having a thyroid problem, we need to manage it very closely. I would see them with blood tests possibly every 4 weeks, and adjust their thyroxine. And the conditions are usually autoimmune. What does the thyroid do? It does increase the baby's premature and causes some neurocognitive or neurological development. So we have to be careful, and we need to increase the dose of thyroxine by about 25 or 50% during pregnancy. And we check.
All right, thank you so much, Dr. Imran. And we have received many questions related to diabetes anyway in the Q&A. So if you can please go there and try to answer as many as you can in the meantime. Thank you very much.
Thank you.
Thank you. I will take this opportunity to thank all our sponsors who have been very generous and extended special discounts to all of you. And with us now from Future Health Biobank is Mr. Carwan Edwards, who will talk to you a little bit about stem cell storage. Over to you, Mr. Carwan.
Good morning, or good afternoon now even, sorry. Can you see my screen okay? Everything okay?
Yes.
Perfect, okay. Well, firstly, thank you for giving me the opportunity to participate in this wonderful event. It's a pleasure to partner with such a prestigious centre such as King's College Hospital. My name is Kieran. I'm the Scientific Projects Manager at Future Health Technologies. So today I'll be talking to you about the importance of stem cell banking. I'll start by giving an overview of Future Health Biobank, who we are and our values. I'll then move on to stem cell banking and why it is so important. And then I'll finish by speaking a little bit about COVID-19 and how stem cells are contributing to the massive research effort currently happening worldwide. So, firstly, who are we? Future Health Technologies was established in 2002 and was the UK's first cord blood bank to be licensed by the Human Tissue Authority, the HTA. Since then, we have grown to be the UK's largest stem cell bank. We've stored more than stem cell samples per year than all other cord blood banks combined. We've also evolved and established the Future Health group of companies, which offers a wide range of services and works with a number of research centres and hospitals. From the timeline, you can see that Throughout our development, we've picked up a number of licenses and accreditations, as for example, the MHRA, OFSP, AABB. We pride ourselves in our levels of quality and are now one of the world's most accredited stem cell banks. So we've processed and stored over 200,000 stem cell samples from over 100,000 families worldwide. As the industry leader, we have trialed all of the leading cord blood processing technologies over the past 18 years. Having fully evaluated these other systems, we opted to use the MacroPress Smart system. So working with the manufacturer of the system, we have optimized the system and can now achieve stem cell recovery rates of up to 99% recovery rate, which means of all the stem cells we receive from the cord blood, we're able to make sure that up to 99% of those stem cells are prepared adequately for the cryopreservation. We've also released 118 samples worldwide for a whole range of different conditions. So Future Health Biobank is present in over 94 countries worldwide, from areas such as Europe, the Middle East, North Africa, South America, and Africa. Sorry, that should have been North America. We are the only stem cell bank to operate 4 separate cryogenic storage facilities in 2 geographically separate locations. So we have fully accredited and licensed to the highest standard facilities in the UK and Switzerland. This gives us the ability to store your samples at either location, so within the UK or Switzerland. We also provide the option to split your stem cells into multiple portions, with portions being stored at each site, so portions in the UK, portions in Switzerland. This maximizes the security for your stem cells. We operate state-of-the-art facilities with a storage capacity of over 500,000 samples, so there's plenty of room to expand. The samples are monitored around the clock to ensure they are secure, and our facilities are alarmed and have on-site security 24/7 to protect your samples from any unauthorized access. This slide shows our unique collection kit. So upon opting for the service, we provide our clients with this collection kit. Everything which the healthcare professional requires to collect the sample is provided within the kit. Stem cells are very delicate. They can be damaged by adverse temperatures, high temperatures. So we have a nanocool technology within our kit, which is designed to provide full protection to your stem cells by maintaining an internal temperature between 4 and 15 degrees Celsius, which is the optimum temperature to keep your stem cells alive until they reach our laboratory. Once activated, the nanocool engine starts cooling the interior of the kit within seconds and will continue to work until the sample reaches our laboratory. So what is stem cell banking? Simply put, stem cells are the building blocks of life. They possess the abilities to become other cell types and to multiply indefinitely. Stem cells are the starting point for all other types of cell in your body, but they're also essential for growth and healing throughout your life. The field of regenerative medicine looks at how stem cells may be used to repair a wide range of diseases and conditions using their natural abilities. So within cord blood, the type of stem cells found are called hematopoietic stem cells. So these cells form all of the blood and immune cells in your body. So naturally, they're a good treatment for conditions that affect the blood and immune systems. So this includes blood cancers such as leukemias, lymphomas, as well as immune disorders such as severe combined immunodeficiency disease. In total, they're now used as standard therapy for over 85 different conditions, and they're used to treat other conditions such as autism, ALS, and aiding recovery in stroke patients is being investigated in clinical trials. And there's currently over 100 clinical trials using cord blood, recruiting participants for a wide range of conditions. Cord tissue contains a type of stem cell called mesenchymal stem cells. So these cells form the solid tissues of the body, such as bone, cartilage, muscle, and fat. And they're also thought to be fundamental in the development of nerves as well. However, they also have the ability to change how the immune system behaves. A huge number of diseases are driven by an abnormal immune reaction. So inflammation has been found to be a driving factor in a variety of conditions, including cancers, diabetes, stroke, heart disease, autoimmune disorders, and more. There's a long list. Researchers are hoping that we can harness this immunomodulatory ability to treat a wide range of conditions, such as those on screen. So autism, cerebral palsy, diabetes, Crohn's disease, rheumatoid arthritis, as well as cardiac repair. So these are all conditions currently undergoing clinical trial. So just to recap, cord blood stem cells are routinely used to treat over 85 conditions. Cord tissue stem cells are in clinical trials to treat over 300 conditions. Recent evidence suggests that 1 in 3 people could benefit from a stem cell treatment in their lifetime. So this is a statistic which is growing as more conditions are proven via clinical trial to be treatable using stem cells. Back in 2008, the number was 1 in 200, and it's now at the most recent evidence shows 1 in 3. Storing a child's umbilical cord stem cells is a once-in-a-lifetime opportunity. They can also be used to treat siblings and other family members. So this is Laith Abu Arish. So Laith had Fanconi anemia. It's a genetic condition which leads to bone marrow failure and is often life-threatening. When his sister was born in 2010, Laith's parents decided to store his sister's cord blood in the hope of being able to treat Laith. Her cord blood was collected at birth and was processed and stored at Future Health Biobank. Following testing, Laith was given the good news that his sister was a high-quality HLA match. This is the fingerprint, as it were, which determines whether a recipient can receive a transplant. The sample was transported to Jordan, where it was thawed out and infused without requiring any additional processing. So this is important. It shows that our processes are effective. The treatment was a success, and Laith had no serious complications. He continues to live a normal and healthy life and frequently visits our office in Jordan. So I'll talk briefly about COVID and how stem cells may be able to assist. So I'm sure we're all aware, COVID-19 has changed the face of medicine forever. There's no doubt about it. There's been a huge research effort globally to find effective therapies for COVID-19. One of the characteristics of COVID is it causes an overreaction of the immune system. This results in severe damage and inflammation in the lungs, as well as other areas such as kidneys, possibly the pancreas as well. There's a lot of research going into it. This inflammation reduces the ability of the immune system to fight the virus. MSCs have immunomodulatory properties, as we said, which means they have the ability to regulate a normal immune response. So far, there are 17 completed clinical trials investigating use of MSCs in treating COVID, and the results so far have been promising. One of the most notable clinical trials was the highly successful trial at the Abu Dhabi Stem Cell Center, in which they treated 73 patients with stem cells. The stem cells were inhaled via a nebulizer. So the stem cells were collected from the blood and aerosoled after being activated. and inhaled into the lungs. All patients have since recovered. What I'll do is I'll pop the article on this clinical trial in the chat after the presentation. There are currently over 70 clinical trials ongoing worldwide looking at how stem cells could be used to treat COVID, with the UK and the US leading much of the research. So we at Future Health Biobank, we're actively working with a number of research groups to contribute to their COVID-19 research. And with the ongoing clinical trials using stem cells to treat COVID-19, as well as many other conditions, the importance of stem cell storage is currently at its peak. If anyone is concerned about how COVID may impact the process of storing your child's stem cells, we have a fantastic blog on our website to answer any questions. Again, I'll drop the link into the chat afterwards. It's also a pleasure to say we've partnered with King's College Hospital to provide a special rate for stem cell storage for all participants of this event. A voucher will be supplied in the chat shortly. And I'll be more than happy to take any questions. Thank you for your time.
Thank you so much, Mr. Chiron. We have received some questions on the chat box and Q&A relevant to stem cells. If you can please just type in answers to these. And now we are going to move on to our next session with Dr. Eleanor McCarthy, who will talk to you about postpartum depression and the baby blues. Over to you, Dr. Eleanor.
Hi, everyone. Good afternoon. My name is Dr. Ellie McCarthy. I'm one of the family medicine consultants at King's. So I'm going to be talking to you about all things pregnancy, of course, but talking about baby blues and postnatal depression. My role within the team at King's is I get the good part a lot of the time of doing the pregnancy test with couples and congratulating them and guiding them onwards and directing them on to the obstetricians. And I quite often get to see you lovely ladies throughout your pregnancy with kind of more minor ailments, I guess, non-pregnancy related problems along the way. Which is lovely. And then after delivery, a lot of the time people will work with me and the paediatricians to look after your baby and to look after your whole family. A bit of background about me quickly. I'm a mum of 3. My youngest is 18 months, so I can remember being pregnant, I can remember delivering, and I can remember postpartum. I still am postpartum, I guess. And I can remember how it feels, certainly when you've just given birth and you don't know what's going on. So I don't have a presentation, I'm going to talk. I've got lots of questions to work through as well, and I'm happy to answer, of course, any questions afterwards. So baby blues, you know, when we give birth, it's a wonderful time, it's a scary time, whether it's your first baby, whether it's your 5th baby. And obviously hormones are fluctuating, our sleep pattern changes, everything, our world changes. And in those first couple of weeks, we can suffer from lots of different emotions, and it's not always a happy time. We're worried about our baby, we're worried about, are they healthy, are we healthy, are other children healthy, our husband, our family, and that can present in lots of different ways. So I'm here to really tell you about the symptoms, I guess, of baby blues and postnatal depression, how we differentiate between them and what we do and how we can help. So baby blues, first of all, commonly presents within the first, you know, most of us have it within the first couple of weeks. When we first give birth, we're initially, you know, pretty elated. Of course we are, we've just delivered a wonderful big bundle of joy into the world. But, you know, in the first even 3, 4, 5 days, that can sometimes crash down around us as our hormones change a lot of the time as well. And we can actually get quite sad and quite teary and feel worried and anxious and not wonder, are we doing a good job? Are we not? It can present with physical symptoms as well. It's not just feeling, you know, sometimes people don't necessarily feel sad or anxious. They can actually feel short of breath. They can get palpitations, and they can get pains in their chest. They can feel shaky. They can feel dizzy. So, of course, you know, you are focusing on a new baby, but don't ignore symptoms like that. We have a fantastic, postnatal service as well, with midwives touching base with you afterwards if you like that. And it's a really valuable service because we focus so much on the baby, and it's nice to have someone ask how you're doing as well, because once the baby arrives, quite a lot of the time we're forgotten about, and we have to remember about ourselves. Postpartum depression, postnatal depression can present much further down the line. We commonly see baby blues coming on in the first couple of weeks, and then quite a lot of the time it lifts. But for some women, they feel fine in the first few weeks, and it's actually in the first few months and even longer, up to the first 12 months we can see it. And we are beginning to recognise it even beyond that time frame. It's called postnatal depression, but it doesn't necessarily mean you're depressed. Again, it presents with a variety of symptoms, and it can sometimes, for some people it's anxiety symptoms, for some people it's depression symptoms. I always sort of try and say to couples and patients to talk about what it's going to be like to have a baby, and to maybe talk about it while you're pregnant. The things that we all get excited about are, what pram are we going to have? What colour are we going to decorate the nursery? The practical things, but it's worth having a conversation with your other half, how you think you'll feel when you have a baby, because it changes your world, it changes your relationship. You've suddenly got someone else to focus on. So if you've had that discussion beforehand, it makes it a bit easier afterwards to talk about it and to open up about it. So that's the first thing I would say. Symptoms that you can get, again, people can feel anxious, they can feel teary, they can feel sad, they can feel that they're not doing a good job, along with physical symptoms as well, palpitations, chest pain, dizziness, all of those things. So what I always say to patients, to ladies, is to talk to someone, and it doesn't have to be me. It doesn't, any healthcare provider that can signpost you where you need to go to talk to people, and where you need to get, where we can give you some help and some guidance. The other, treatments that we have, there's a variety of treatments, and the treatment plan is always individualized for the patient. And that is, that looks at different techniques. Some people can use breathing techniques, meditation, yoga, light exercise, and there are talking therapies that we have. We can direct you to those. Just to touch on, there are also medications that we use. We have pregnant women with anxiety and depression that are on medication. If we can take them off it, we sometimes look to, but we always look at the risk versus the benefit. So medication in pregnancy is okay, and again, after pregnancy, if we have to give people medication when they're breastfeeding, we can do that. It's safe to do that. So it's never something we would rush into, but it is there, and we do have it. So I've got a lot of questions as well that were sent in beforehand that I'm going to chat through, and I'm 1 second. Okay, so first of all, a question about exercise in pregnancy. Exercise is perfectly safe. We want you to exercise. It will keep you healthy. It will keep baby healthy as well. And in terms of if you were exercising before, we say that you can exercise to that level. If you were, you don't need to go out and run a marathon if you weren't running a marathon, but certainly continuing to exercise. It doesn't have to be strenuous exercise. Light cardiovascular work is perfect. And, keep doing that, but you do not need to push yourself, certainly. Someone has also asked, how much should I exercise daily to have a normal delivery? Certainly, I'm not sure that exercise necessarily will influence whether you have a normal delivery or not. That's not, I would perhaps direct that question to one of the obstetricians, but I wouldn't necessarily suspect that exercising will make you more likely to have a normal delivery. Certainly, there are things that we suggest on the run up to delivery to try and get baby to come down, but it's not going to influence whether you have a normal delivery or not. What can be done to, I've got a question, what can be eaten from the first month onwards if we want a healthy baby? Keeping yourself healthy will keep baby healthy. Someone's also asked, is it okay to have a takeaway in the first trimester? Of course it is. Certain foods that we'll tell you to avoid: unpasteurized milks, not too much liver, pate, and seafood generally we tell you to avoid, but a takeaway is absolutely fine, maybe even during the second and the third trimester. Someone's asked about tips to combat nausea and tiredness. Listen to your body from a tiredness point of view. If you're tired, if you're able to take some rest, that may be difficult. I appreciate either if you're working, if you've got other kids to look after, but just remember and focus on having rest periods if you can. Nausea, there are various remedies that we use. Natural remedies, lemon and ginger tea can be useful. Peppermint tea can be helpful. Some people have really bad nausea and sickness, and again, we do have medicines that we can use for that if we need to. Constipation in pregnant mums, very, very common, unfortunately, and we try and get you to drink lots and lots of water. Drinking lots of water and making sure you've got lots of fruit and veg in your diet is the most natural way that we can get you to manage the constipation. There's also been a question about hemorrhoids. Unfortunately, they're also very common in pregnancy and after delivery. So we want to minimize the chance of you getting hemorrhoids, getting piles. So the way to do that is to drink as much as you can and try and keep a healthy diet. Along with that, unfortunately, heartburn is very, very common. Minimizing the symptoms, again, foods that can cause heartburn, spicy foods. Most women reduce or stop coffee in pregnancy, but if you haven't, keeping that to a minimum. And any acidic foods as well will cause you heartburn. So minimizing that, and sometimes drinking milk, or there are medicines. We don't always give them, but simple things like milk of magnesia and Gaviscon can really help. Another exercise question about sport with weights. Gentle weights, absolutely fine. Certainly not too much tummy or core work. Later in the later stages, listen to your body, but gentle weights absolutely fine. And very upset when she was 4 months, a bit of a struggle with mental and physical health. That won't have affected the child at all. We throughout pregnancy we will have periods of stress. And someone's also asked if when they're angry they've yelled, and will that affect your child? No, it won't. Of course, it's helpful if we can keep calm, have calming techniques, of course, but it will not harm your baby. So don't beat yourself up about that. And I think that's me. If anyone has any other questions, I will be here after Dr. Maria's talk to answer questions as well.
All right, thank you so much, Dr. Eleanor. So Dr. Maria Karokolaki, she's also a specialist obstetrician and gynecologist and specialized in aesthetic gynecology. She will talk to you today about coping with body changes and advanced postnatal treatment available at King's. Over to you, Dr. Maria.
Yes, so before we see what and how we treat the problems, let's go and have a look of the changes that are happening during the pregnancy. So as we all know, the pelvis will be expanded, and that is the reason why the relationships between the organs inside the pelvis will change. And also the growing uterus will put a lot of pressure on the pelvic floor muscles and the pelvic floor nerves. And that will lead to a stretching of the pelvic floor muscles and will make the muscles also weaker. Then we also have changes in the vaginal wall. The vaginal wall during the pregnancy will get engorged. And the same can happen with the labia majora and minora, so the small and the big lips. They can get swollen, and then the skin can get stretched. So having that in mind and knowing that the pelvic floor during the pregnancy has been weakened and also the vaginal wall has been strained, then the problems, the most common problems in after the pregnancy and the delivery are two. Actually, it's the urinary incontinence and then sexual dysfunctions as well. So when we're talking about urinary incontinence, we talk mainly about the stress urinary incontinence. That's the most common problem. This is the condition where a woman will have a leakage of urine when she's sneezing, jumping, laughing, when she does anything that will increase the pressure in the abdomen. Then there is the urge incontinence. This is a condition when you have the feeling that you want to go to the bathroom and then you feel the urge to go. So you have to run and go fast, otherwise you might have a leakage. And then there is the mixed incontinence. Some women will experience both kind of issues. And then looking into the sexual dysfunction, we are talking about painful intercourse after the delivery. Women will complain very commonly and say, you know, the sex is not the same anymore. It doesn't feel the same. I feel that my vagina is loose, or the sensitivity it's not okay. Or other issue is that the vagina might be dry, and that will make the intercourse even more painful. And then sometimes it's not very common, but there are complaints about the changes in the appearance of the genitalia. And also less common, but it can occur, is that the scars we have from the episiotomy or the tears, they can be painful. And here I would like to say that thankfully the nature takes care, and usually these kind of problems, they will be solved after a while. But sometimes women do struggle for a long time with these issues, and unfortunately sometimes also they will not recover, and then they need treatment. And you know, as for now, or let's say until very recently, there were very few things that we could do, and we could help the women to deal with this kind of problems. So what we had until now for the urinary incontinence was the pelvic physiotherapy, which is great and works very well in many cases, but it takes very long time, maybe more than 3 months, and a lot of effort. So you have to be very disciplined, you have to do your exercise at home. It's not enough if you go for your session and that's it. And then of course for severe cases, anyway, there is a surgery. This is still the same. But for sexual dysfunction, we were many times really helpless. We could use some lubricants, maybe numbing cream, maybe in advanced cases estrogen cream, and that's all, nothing more than that. And this is where functional gynecology comes now with new treatments. What we use to treat the problems is the laser. We use PRP and the hyphen technology. So I will come to that later. Actually, the laser works through increasing the temperature in the vaginal wall a lot. So it's a thermal effect, and that will stimulate our own healing process, so that the vaginal wall will be restored, will be regenerated. Then the plasma, maybe you have heard about it from treatments in the face or from orthopedic surgeons. Actually, for you, it's like a blood test. You come in the clinic, you have something like a blood test. Then we will take the blood, we will work it out, and we will take only the plasma out of the whole blood. And that plasma is very rich in growth factors, and wherever you inject these growth factors in whatever tissue, you will have a remodeling. So you will have a new, healthier, healthy tissue. And again, the hyphen technology, I will come in a while to that. So laser and PRP treatment, we use it for vaginal regeneration, and we use it also to treat urinary incontinence. Both the laser and the PRP, they stimulate the production of new collagen, new elastin, and new blood vessels. So the blood flow in the vagina is very increased. And then the PRP additionally activates the stem cells of the injected tissue, and therefore we will have the remodeling of the tissue, as we said, and also regenerates the nerves. And that helps a lot with the sensitivity. So women that complain about having lost their sensitivity during the intercourse, the PRP works very well with them. So both are very easy, and they are not painful at all. The procedure will be done either at the same day or with a 1 day difference. The laser lasts 10 to 15 minutes. You don't need a numbing cream for that. It's not painful at all. You just feel the heat of the laser, nothing else, but it's not uncomfortable. There is no downtime, and it's only 3 sessions within 3 to 4 months for both PRP and laser. So what we expect from the laser and PRP treatment, we expect that the old, let's say, non-functional vaginal wall will be replaced by a new functional vaginal wall. We have improvement of the urinary incontinence, and in many cases we have final treatment. So the patient will not need to do anything more than the laser or the PRP. Regarding the sexual dysfunction, we expect a painless intercourse after the treatment. The friction during the intercourse will be better, so that the vagina feels tighter. This is the so-called non-invasive vaginal tightening. The sensitivity, of course, will be much better, and the vagina will be well lubricated, so no dry vagina anymore. And the PRP works very well for the orgasm enhancement. This is a so-called OSOT. And of course, if we have a strong vaginal wall, then we have less chances in the future to have a prolapse of the pelvic organs like the bladder or the rectum or the uterus into the vagina. And moving to the HIFEM technology. The HIFEM stands for a high-intensity focused electromagnetic field, and we use it to treat urinary incontinence, and also we use it for sexual enhancement. So basically, it's a chair. We call it Emsella chair. And how it works is that inside, on the bottom of the chair, there is an electromagnetic field. So this field, or the energy that comes out of the field, will stimulate the nerves of the pelvic floor. And then the nerves will stimulate the muscles of the pelvic floor. And with this treatment, within 28 minutes, you get 11,300 contractions in your pelvic floor muscles. Which is amazing. I mean, if you think how long you would need to reach that number of contractions, I'm sure that the time is really, really long. And it's not only about the number. It's also about the strength of the contractions that you get with this kind of treatment. So I have a graph here. If you see on the left side, you see the contractions that we get when we do the right Kegel exercise, because that's also important. If you have weak pelvic floor, you can't do by yourself the right Kegel exercise. So the contractions will be very weak. But let's say you have muscle that can generate a good contraction. Then this is what we get. This is what you see on the left side of your graph. On the right side of the graph, you see the contractions generated by the Emsella chair, which are much stronger, and they last much longer. And from one side you get very strong pelvic floor muscles, and from the other side, which is very important, you get your muscles also re-educated. That means that because the energy of the electromagnetic field will act to the nerves and not only to the muscles, it's not a passive exercise. So your muscles will get re-educated and they will be able to control your bladder function. So that means that whenever you laugh, jump, whatever you have done and you had leakage, now your bladder, your pelvic floor will be able to contract and control the bladder function, and so the leakage will not be there anymore. For the Emsella chair, you need 3 weeks. It's a 3 weeks treatment. You come to the clinic for twice a week for 28 minutes. And that's it. Maybe after a year you will need one memory session, but nothing more than that. And also the Emsella is an FDA approved treatment and has clear indication for all kinds of urinary incontinence. So what to expect after the treatment with Emsella chair? You expect that your urinary incontinence will be treated. If the chair has 2 protocols, one is for the urinary incontinence and the other is for sexual enhancement. If you choose to take the protocol for the sexual enhancement, then you expect also to have an increased sexual desire and improved orgasm. And also because you have stronger pelvic floor muscles, that's why in the same way that you will be prevented if you have a strong vaginal wall, if you have strong pelvic floor, you will be protected, or let's say the chances of getting a prolapse into the vagina of the pelvic floor organs will be less. And then regarding the cosmetic procedure, sometimes, again, not very often after deliveries, but it happens that women will not be happy with the changes. And then we do offer the laser, the PRP, and also hyaluronic acid fillers to correct the problems. And if someone needs something more profound in regards to the appearance, then there are also surgical procedures like the labiaplasty for labia minora, for labia majora, clitoral hood reduction, perineoplasty, and vaginoplasty, which is actually the surgical vaginal tightening. And in King's, we always like to work as a team. And in the Clinic for Aesthetic and Reconstructive Gynecology, in cases we have severe and complicated urogynecological problems, we refer our cases to Dr. Amitabha. He's our consultant OBGYN and super specialist in urogynecology. And again, if the cases are complicated enough, then he takes care and solves the problem. So I will be more than happy to see you for a free consultation in our clinic in Marina. You can see the numbers. You can WhatsApp if you want. And yeah, thank you very much for joining.
Come along as we take you through what they have to offer. What makes King's unique? Now, I actually have a lot of experience in knowing what women want, particularly in this region. I'm a clinician and I've been practicing in this region for over 11 years now. And I've seen what women are asking for and what women want in this region. What we try to do here at King's is a little bit different. We're trying to bring in that British model of care that you would expect if you were to go into a hospital in London to receive that care here in Dubai.
I think what initially attracted us to King's College Hospital was the fact that it's a British hospital and it's got that famous British name, and that really put our minds at ease, didn't it? And then when we visited the hospital, we were really impressed with the British trained midwives, the state-of-the-art facilities, and that was really attractive to us. The midwives were amazing throughout the whole experience. When I came into the hospital, they were really reassuring, really welcoming. In fact, all the staff were, even down to like the Kingsmen, who welcome you on entry to the hospital.
Here at King's, we deliver antenatal education courses to our patients, and we do this for patients and birth partners to prepare them for all aspects from antenatal, during labour, and for the postnatal stages of pregnancy. We do things slightly different here at King's, whereby we have our antenatal courses that are delivered by midwives, and all of the content has been prepared by obstetricians and midwives working closely together. We make the sessions fun and interactive, and a more friendly approach rather than just standing and sort of dictating to our patients. We make it fun.
There was 3 antenatal classes that we came to. They were brilliant. So they talk you through what to expect in the build up to pregnancy, throughout your pregnancy and after your pregnancy. They were really useful. The midwives were lovely. And I really liked as well that they used different midwives for each class, so you got to know more of the staff. So then when you came in and had your procedure or you gave birth, you felt like you knew the familiar faces, and everyone was really friendly, and you'd seen them again, and it was really nice, wasn't it? They were really useful.
Fetal medicine is the care of the baby, the assessment of the baby. So traditionally we look after mummies and we have the babies as well, so we look after them as a unit. Fetal medicine is where we actually look at the fetus as an individual, and we do the necessary regular assessments that are required within pregnancy. It's a new subspecialty, relatively new in the region, and we're proud to be having a fetal medicine centre here. We have a 4-bed labour ward, often home away from home services. We will care for you, you'll be able to relax within our spacious environment. The rooms are really large, comfortable. Upon arrival to the hospital, whether it's antenatally or during birth or postnatally, you will always be greeted by one of the midwifery members of staff, who will guide and assist you. If you do present in labour, you will be cared for on a one-to-one basis, so you will have that close rapport with one of the midwives who will advocate for you, who will care for you, and will contact a doctor if there was any problems identified. Majority of us are expats here. We don't have that family support. We don't have the ability to particularly with breastfeeding. So what we have here is a twofold. We have the mother and baby clinic, whereby women can drop in at any time if they're having any issues, any difficulties at all. And then we have our home care as well. So that means a midwife actually goes back to your house and supports you in your own environment. Now that is something that's new, and delighted to say that we have the seconds.
We realised that postnatal care was less prevalent here in the UAE. So the Well Mum and Baby Clinic promotes continuity of care postnatally for mums, babies and dads. So we offer a service to do postnatal checks on mum and baby, weigh babies, breastfeeding support, and support for dads as well.
Once we've been discharged from hospital, and we went back home, after 24 hours we had the home care service, so the midwives came out to us, which was really good after 24 hours, because you're kind of a bit scared of going home, everything's new, and so they came out and just made sure that we were all right and that the baby was all right, and if we had any questions, we had a big list of questions, because everything starts worrying you when you get home. So the midwives were fantastic. They put our minds really at ease.
Expectant mums should choose King's because we have a fantastic team of nurses and midwives who are all trained to a really high standard, and we only practice evidence-based care. So what we're really trying to bring in to the Dubai market is that trust. The trust that when you walk into King's College Hospital in Dubai, you know that the level of care that you are receiving is of the highest quality.
I definitely recommend King's to other people because I think the consistency of the care that you get amongst the midwives is fantastic. So all of the advice that they're giving you is consistent with each other. You're not getting different opinions or different approaches to things. So it kind of puts your mind at ease. And definitely the hospital itself, it's phenomenal. The support that you get here, the facilities here, it's just amazing. It's like staying in a hotel. It's great.
we have, as obstetricians, as clinicians, as doctors, pledged on a manifesto of care. All doctors at King's have signed on to say that we would do what's right for the patient at the right time. So no over-treatment, or no over-management, no over-prescription. So what you will receive, the care you will receive at King's would be what you need as a patient.
So that's the end of our maternity tour at King's College Hospital London in Dubai Hills. We hope we've assisted you in understanding their facilities and you make the right choice. Thank you.
I think Dr. Gowri, our CMO, has touched on it, that we are very much, driven by what the DHA rules and regulations are. So, and at the same time, King's, really want to fulfill the wishes of the women. A lot of our staff, midwifery staff who actually conducts water birth are, stuck abroad, as you know, and they are making their ways. So it is at the discretion of the obstetrician and gynecologist at the moment, and we are, some of us are allowing for the water birth still to happen. But if there is a midwife not available during your labor, then we can allow you to at least labor in the water. Okay, the birth might be you have to come out of the water, and this is all because of what is going on in the country. Of course, it's nothing to do that we would not allow, but it's just the resources, the way the DHA rules and regulations, and if we put everything into perspective, it is becoming slightly harder, but things are getting better. And I think things will change in another week, and so we are very positive that it will start full gear again, water births.
Thank you so much. Another question we have from Mrs. Ishita. I am 24 weeks pregnant and have been drinking green tea every morning, but now I read that it reduces cell development and lowers folate absorption. Did I do any harm to my baby?
No, not really. Green tea is actually one of the best tea. If you do drink tea, you should drink green tea. I want to remind people that the organogenesis time when things can affect the fetus is the first 8-9 weeks of pregnancy. Okay, and after that, it is there's very little which can affect the fetus. So green tea, coloring your hair, and this kind of a stuff is just completely irrelevant. Please live normal life. You are just pregnant. You are not sick, and do exercise, eat healthy, do whatever you have been doing before. Of course, we are not talking about alcohol, but other than that, live normal life. And, you're not harming your baby in any way with the quality of life that we are living in Dubai. And thank God for that.
A lot of questions we're receiving about diabetes, and I can see that Dr. Imran is doing a great job answering all in the chat box. So thank you very much. Okay, we have another question. A question I have, I don't know who's the most appropriate doctor to answer it. Is it advisable to do pelvic floor exercises during pregnancy?
I think Maria can answer this in part as well, but yes, of course, who's going to ever say that it is not important? Pelvic floor exercises, pregnant, not pregnant, no matter what, are very, very important. And it's very easy to go on a Facebook and put in pelvic floor exercises or Kegel, and please do them. The thing with the pelvic floor exercises is when you stop, they go back to just like any exercises. If you go to gym every day, you will be in a perfect shape. You stop for a few weeks, few months, of course you are just like all of us sitting on the chair all the time, have a bit of a belly and a flat bum. So pelvic floor is not any different than the rest of your body. It muscles. So you must exercise. But Maria can even answer it more in depth. Maria, please.
So yes, pelvic floor exercises like Kegel or other exercises that you can find in YouTube, that's true, or you can have with your trainer, is very important even during the pregnancy, so that you help the pelvic floor to deliver better, the process of the vaginal delivery. But also, to have a strong pelvic floor during the pregnancy is very important as a proactive approach for later in life, so that you don't get issues like prolapse, loose vagina, mainly prolapse and urinary incontinence, of course. So yes, absolutely. There is not only one thing which is right. For each and every case is different, but pelvic floor exercises at any stage are very important.
Thank you, Dr. Maria. I'm still going through the questions and many related to your topic. I would just like to tell everyone again that we are offering free aesthetic gynecology consultations, one-to-one with Dr. Maria Karokolaki. So you can discuss post-childbirth rehabilitation with her directly. I've placed the number if you would like to book an appointment with her in the chat box. Okay, I have another question. How can we decrease the level of acidity during the 8th week? This causes a lot of vomiting to me.
Imran, do you want to answer that as a physician? No, I can answer that, of course. So acidity, pregnancy, because you are not eating that much in the early stage of pregnancy, or you are vomiting, you are feeling nausea. And remember, the pregnancy changes are amazingly very fast. You think you are only 8 weeks pregnant, but by 8-9 weeks, your plasma level or your blood level almost doubles. All the changes are almost there. So the emptying time of the stomach is very, very slow. So the juices that you produce to digest stuff, it stays there for a long time, and you develop this acidity. So there is medications, and there is this awful thing that we give, and you can, drink that. So really, it's very simple. Speak to your obstetrician, because they can advise you and they can give you a prescription for all that. And it will, the commonest thing we give is Gaviscon, and you can respond to that. But you can also take Zantac, which is over-the-counter tablet, and it's very safe in pregnancy. So have a chat with the obstetrician. There's a lot of stuff that you can have which will help you with this.
All right. Thank you, Dr. Samina. I'm just looking at the questions. Okay, someone is asking, when can we start vaginal prolapse treatment after birth? After how long? I believe that's for Dr. Maria as well.
I think I just answered that question, but usually we give 8 weeks time until we see if the body will recover by its own. And if women still struggle with the same issue, then it's advisable to have at least a consultation and examination, and then we can start with treatments.
Okay, hope that answers your question.
While you are reading questions, can I ask Imran, because I think a lot of people wonder. So Dr. Imran, I think a lot of patients ask at what stage it is important that they should see endocrinologist if they have a thyroid problems, if they have a diabetes problem, they have a strong family history of diabetes, or they have a, this kind of a medical endocrinological problems. What do you recommend at what stage they should see an endocrinologist?
Thanks for the question. Yes, I've tried my best to answer hundreds of questions. I don't know if there were 100, they felt like hundreds. But it's very important to reduce my workload and Samina's and everyone's if we had preconceptual consultations where You could have a one-to-one discussion with myself, the obstetrician, dietitian, but in order to prepare you for pregnancy. And if we can work towards that and reduce your risk, then we don't need to go through the glucose tolerance abnormalities and starting you on tablets or insulin, which are quite challenging for mothers. There's lots of worries there, and then to start injecting is another worry, though we make it very easy. So I think if you have the risk factors which we've highlighted before, polycystic ovary, obesity, family history of diabetes in close relatives, higher BMI, all these patients should actually have a consultation beforehand to prepare them. And it takes about 3 months at least, if not longer, to reduce their risks. As far as the thyroid is concerned, yes, it's very important to make sure that the thyroid function test, in particular the TSH, is adequately replaced, because most of the baby's formation is in early time. So we want to come in early and make sure that the thyroid function tests are regulated and treated with the right amount of thyroxine. There are some cases, though not uncommon, to have an overactive gland, but we mostly see hypothyroid. And again, prevention is the answer, and preparedness is the answer, and not to leave it and then trying to manage it once the problem has arisen.
Thank you. That is brilliant.
Thank you so much. Yes, doctor.
Because a lot of my patient asks, and I think now that I have Maria here, I'm going to use her and abuse her. Maria, a lot of patients, especially, in the population which is South Asians and Middle Eastern, the pigmentation of pregnancy is quite severe, right? On their faces and on the genital areas and the nipples. And, we live in the age of genital awareness, right? And so, we are sensitive towards these things and these problems. So one of the questions my patients ask, how soon, now that you have treatments against these pigmentations, how soon they need to, how long they should wait? I mean, some of these pigmentation changes are reversible, body does it themselves, but some are not. So I know you said usually 8 weeks, but for pigmentation, how long people should wait?
Even longer.
Okay.
So even longer. I would give at least 6 months, at least, even a year, so that we know. And now that you raise the subject of the pigmentation, because they are asking about bleaching, women have to be aware that we cannot bleach and whiten everything. So if the area is very dark, then there are few things that we can do. So laser and bleaching creams and things like that we use for not that dark skin type cannot be used. So it's better to give it a time, 6 months to 1 year at least, and then it might become even lighter, and this is where we can intervene with the laser and the bleaching and the BRP and everything.
Fantastic. Thank you.
Yeah.
Lovely. One of the questions we received, does urine infection really affect the baby as it's not going away? So
yeah, I can answer that as a high-risk obstetrician. Yes, renal infections you are more prone to them in pregnancy anyway. And that is why your urine sample is checked at every visit to make sure that you don't have, sometimes you don't even have symptoms, but you have what we call it asymptomatic bacteriuria. So it needs to be checked. If positive, needs to be treated. It can put you at high risk of a preterm labor. An infection anyway, if you are diabetic, it makes your diabetes poorly controlled, and Imran will agree with that. So sometimes some patients can have a repeated urinary tract infection in pregnancy. You treat them once, then they end up coming back again. They are very much the candidates who should be referred to the nephrologist, a renal physician, So they can be checked. We would do an ultrasound scan in pregnancy, though it is not very accurate, and usually it will show abnormalities, but these are pregnancy changes. And sometimes they are put by those physicians prolonged treatment, an acute treatment of one course of about 10 days followed by a one-night treatment. Sometimes it has not been proven of much benefit, but I think it is important they are referred to the physician, nephrologist, kidney physician, to be seen. Very important that we involve multidisciplinary team and the obstetrician doesn't try to do everything themselves.
Okay. Enrico, how soon after birth can we start hair laser removal treatments as well as Botox and fillers? I think this is for all of the doctors then.
How soon after delivery?
Yeah, yes, exactly.
So I would say for the laser treatment in the area, it's good to wait at least 2 months. But as for the Botox and the fillers, the soonest. There is no reason that you should wait. You should feel well and nice and beautiful. So go ahead with that. That's fine.
She's right, Rama, but just be careful because the pregnancy causes a lot of water retention, and Maria will agree that you might overdo it and might do it in the wrong places, especially the fillers. Botox, yes, no problem, but Botox can get diluted if your body has a lot of water retention. But she's right, it's very important that you feel beautiful in yourself, yes. So, yeah, I think our, what is it called? We have a magnificent doctors, aren't we, who has joined us, a specialist, yes, Dr. Praga, of course. Would have been lovely if she was here online, but ask your attendees to see her. She's magnificent.
Of course, yes, she is.
May I just add here something?
Yes,
she just came to Marina Clinic, where King's Aesthetic is located, and we are so lucky and so happy to have her. And yeah, she does amazing things. She's very experienced, and I think every woman would love her and benefit from her treatments.
Yeah, I'm going to go and see her soon as well.
Oh, me too.
Thank you, doctors. For those who are listening and interested to read more about Dr. Bega, I will insert a link directly for her bio for more information. Now we shall continue with our conference, and with us is Dr. Ruba Abdel-Noor. She is a specialist pediatrician and adolescent medicine. She will talk to you about vaccinations for your newborn after delivery.
Good morning, everyone. I'm so happy to be here, and thank you for everyone who stayed until now in the conference. So I have a couple of slides that I would like to share with you. Let me just share my screen.
Yes, we can see it.
Okay, perfect. So, it's a very good time for pregnant moms to start thinking about their newborns and everything that happens after delivery, including vaccinations, because, after birth, the mom would be overwhelmed. She has many things going on. So it's good to have all the information that she might need prepared ahead of time. So the first thing I would like to talk about is how do vaccines work? Because I think in order to be able to make informed decisions, we need to know the concept behind things and why we vaccinate. So here, in order to understand how vaccines work, I'm going to start by explaining how a disease works and how we get immunity when we catch a certain virus or a certain bacteria. So we get our germs, and I'm a pediatrician, so I like cartoons. So these germs enter the body, whether it's through the respiratory system or the skin, or the digestive system. And what happens is that the body, you can think about it as a fort, and there's an army protecting the fort, which is our immune system. And our immune system is very, very complex. It has many organs, many cells, many molecules that are involved in it, and they coordinate all together to fight off infections. So basically, this army recognizes that, you know, there's something abnormal, there's a foreign invader in the body. And after that, we have the symptoms of the infection. So for example, let's say we have the flu or the influenza virus. So we get the high fever, the cough, the chills, and so on. So what happens then is that the immune system will start producing antibodies, which are the molecules that are going to fight these germs. And eventually it will help us to get rid of the germs. And at the same time, our immune system will remember this germ through a process called, memory cells. And in the future, whenever our body is exposed a second time to the same germ, our immune system will remember it and will fight it off before we get this infection. So this is basically the concept of how we get our symptoms. And this is how vaccines work. So what happens in vaccines is that we get the virus or the bacteria, and we either kill it, which is the case for most vaccines. So it's a killed virus. The particles that cause the infection are removed, processed, or it is weakened. So it's still a live germ, but we make it weaker to the point where it cannot actually cause a disease when we introduce it to the body. And we administer it to the person, the child, or the adult. And the same way, our immune system will recognize it. However, in this case, we will not get the sickness because the virus or the particles of the virus that we injected in the body are not strong enough to give us the disease. So our body will just mount an immune response. We might get very mild symptoms, but in most cases, we won't get any symptoms. And at the same time, we develop this long-term immunity. And this is just to explain to you how the cells, some of them will go on to producing antibodies to fight off the acute infection, and others will create memory and will be stored in our body for a long time, ready to fight off whenever we see the germ again. And this is briefly to show you how whenever we are exposed to a germ, we get an immune response. So the number of antibodies in our body will go up. And then the second time we get exposed to it, so whether it's after a natural infection or after the virus, we get a secondary immune response, which is faster. As you can see, the curve is sharper, and the response is much, much larger. So this is really what makes vaccines one of the most effective ways of protecting our children and boosting their immunity against all of these vaccine preventable diseases. The last time I had a talk about vaccines and immunity, it was before the pandemic. So now I'm sure many people are more familiar with all of these concepts because of what we're living. So this is the DHA vaccination schedule. This is the vaccination schedule that we follow here at King's. It includes the mandatory vaccines and the additional 2 to 3 recommended vaccinations. I don't want you to, get overwhelmed with all of that. Those of you who are not first-time moms, if you have older children, you're probably already familiar with all of that. But for the new moms, you have time to discuss these with your pediatrician. But basically, what I just wanted to show you is that we have the 2 main vaccines at birth. We have the BCG vaccine, which protects against tuberculosis, and we have the hepatitis B vaccine. And these are both administered to the baby before they are discharged from the hospital. And then we have vaccines at 2, 4, and 6 months, which are booster doses of the hepatitis B, along with diphtheria, tetanus, pertussis, Haemophilus influenza, polio, pneumococcal, and rotavirus. And then we have the meningitis vaccine at 9 months, and then the MMR and chickenpox at 12 months, and so on. So many parents, when they see the vaccination schedule, they ask us, why do we need so many vaccines, and why do we give multiple doses from the same vaccine? So as I mentioned, we have two types of vaccines. We have the inactivated or the killed vaccine. And for these vaccines, each dose contains a fixed amount of the disease antigen, which is whether it's a virus or a bacteria, and immunity is built in phases. Each time we give a dose, we have a certain immune response, and then the second dose, which is usually like 2 or 4 months later, it will add to this response, and we build this immunity in phases. However, for live vaccines, which are basically inactivated but live vaccines, they contain a small amount of the antigen, which reproduces and spreads throughout the body. And we do recommend, so basically we get the full response from the first dose. However, sometimes we do give a second dose, which is the case of MMR vaccine or varicella vaccine, because there's a small percentage of people, around 5%, which may not respond the first time. Then when we give the second dose, we make sure that almost everyone is immune, or 98 to 99% of people who receive the vaccine are immune. So another question I get is that can all children get vaccinated? So there are contraindications to vaccines, and there are precautions. All these conditions are very uncommon. Most kids can get vaccinated, but kids who have a history of a severe allergic reaction after a previous dose of vaccine or vaccine component, then it's a contraindication to give them the vaccine. And when we say a severe allergic reaction, we mean by that anaphylaxis, so a severe reaction, respiratory compromise. They might get admitted to the hospital for treatment. Some people who have problems in their brain or their central nervous system or encephalopathy might not be advised to take any vaccines that contain pertussis. But this is something, it depends on your child, and we usually go with the patients when they come to clinic. We usually go through all the medical history and the family history of the child before administering the vaccine. So if there's anything, it would be discussed in the clinic. And there are contraindications to live vaccines, like if a pregnant lady cannot take a live vaccine, and people who have severely low immunity, whether it's because they have cancer, they are taking chemotherapy or radiation, or they have a medical condition requiring immune suppressant medications, or if they have HIV, or if they have other types of immune deficiencies. And there are some precautions. So if a child comes to clinic with a moderate or a severe acute illness, we prefer to delay the vaccine. Now, if a child has a bit of a diarrhea or a mild runny nose, a mild cough, if they are recovering from an illness, this is not a contraindication. We can still vaccinate the child. But if they come in with high-grade fever, if they look tired, if they are sick enough to be admitted to the hospital, then in that case we don't vaccinate. And if there's a personal or family history of seizures, then we would not administer just one specific type of vaccine, which is the combined measles, mumps, rubella, and varicella vaccine. Now, what are some possible vaccine side effects? So any medicine can cause a reaction, and vaccines are they're not an exception. Most kids, they have they don't have any reaction to vaccine. Most reactions are minor, like a bit of pain at the site of the injection, or a bit of a rash, or a mild fever that goes away. And some of them might have a more serious reaction, like higher fever, chills, muscle aches, and so on. One thing about the BCG vaccine that babies receive at birth, is that it might cause a local reaction. So you can see like a pimple at the site of the vaccine, and that would go on for a while, and then later on it would heal, leaving a tiny scar. Serious reactions like a severe allergic reaction are extremely rare. Like around 1 in 1 million or 1.3 to in 1 million. And whenever a child takes the vaccine in the clinic, we are equipped to dealing with such type of reactions. What are the benefits of vaccines? So of course, they protect your children from more than a dozen of potentially serious diseases. They provide herd immunity. So when I vaccinate my child, I protect him or her as well as other children in society. And getting vaccinated today will help protect future generations of children. And I always give the example of smallpox, which was a deadly disease in the past, and in the 20th century it killed hundreds of thousands of people all over the world. And the last case, thanks to the vaccine, the last case was in the 1970s, and now the disease doesn't exist anymore, and we stopped giving the vaccine because it's no longer there. And a brief word about herd immunity. We hear a lot about it in the news at the moment with the coronavirus pandemic. This is just to show you that, so everyone in blue, there are healthy people who are not vaccinated, and the people in yellow are immunized and healthy, and the people in red are not immunized, sick and contagious. So if no one is immunized and you have 1 or 2 sick people, you will see that the disease will spread among the population really, really fast. If some of the people are immunized, then these people are protected, and the disease will still spread, but it will not affect them. However, when most of the people are immunized and just a few are not vaccinated, then the virus doesn't have, it cannot jump from one person to another, because these people's immune systems are ready to fight it. So this will stop the contagion, and it will stop the spread of the disease. I'm gonna skip that just not to bore you too much, and I think it's better to answer some of your questions. I just wanted you to remember that now is a good time to vaccinate your older children. So for second-time moms, or if you have one or more older children and you are getting ready to have a baby, and now it's a good time to go over your older children's vaccination booklet to see if everything is updated, because when we vaccinate the household members, we are protecting the newborn from potentially severe diseases. You can ask your obstetrician. My wonderful colleagues who spoke earlier can help you with that. Some vaccines are indicated for pregnant ladies as well, to protect her and to offer some protection to the newborn during the first couple of months. Always check reliable references about vaccines. There are so many websites and so many wrong information on the internet. So always check the sources, check where you're getting your information from, and always ask your doctor and prepare your questions, and you can ask your pediatrician. And we're more than happy to see any pregnant lady in the clinic as pediatrician even before you deliver, just to answer all your questions.
We will move on now to Dr. Maria Teresa. She is our consultant neonatologist, and she will talk to you about caring for your newborn. Over to you, Dr. Maria.
Okay, so good afternoon, everyone. I'm hired to take you through how to caring of the newborn, and I would actually like to focus on 3 aspects. One is how to care for the normal newborn, the premature newborn, and of course, very relevant to the situation today is how to care for the newborn in the current COVID situation. So you know that over 3 million newborn deaths would occur all over the world, and about a quarter, half of this would be occurring within the first 24 hours after birth. It's either babies are born too early or too small, or babies will have some infections, or babies will have problems around the time of delivery. What is important to stress is that labor, birth, and the immediate postnatal period are the most critical for newborn and maternal survival. Hence, it's very important that these parts of the maternal and obstetric care, as well as the immediate management of the newborn, is carried out in a center that is likely be able to deal with most of these problems. Normal term newborns are usually babies who are between 37 to 42 weeks. They're usually of a good weight, and these babies normally have immediate adaptation, and they can establish breathing as soon as possible or as early as possible after delivery. As you can see from those pictures, you have the baby coming out, and that baby is covered with a little bit of a sticky material on the skin. This is called vernix gaseosa, and this is very important for thermoregulation. When a baby is born, there are very important key points that we consider. Of course, we do cord clamping, and now you know that we are advocating delayed cord clamping because of the many benefits that are associated with it. Very important, although it's a very simple step, is actually thermoregulation. Thermoregulation, or keeping a baby's temperature within normal, within 36.5 to 37.5 degrees, has been found to be actually reducing mortality and morbidity in our newborn babies. The next step that we do and that we ensure is that once a baby is born, we do establish breathing. So for normal term newborn babies, this can be done by drying and stimulation. So you can see a baby there who's crying loud. However, if a baby is not able to do that initially, then we can offer support. As in the picture there, where we could give positive pressure ventilation. After babies establish breathing, as part of thermoregulation, we try to reduce heat loss. And so you can see a baby there with a hat on, because most of the body's temperature is actually, body's heat is lost through the head, because that is where the biggest body surface area is for a term newborn. After the initial steps are done and the baby is breathing well, then we try to initiate kangaroo care within 30 minutes after a baby's delivery. Kangaroo care means we do skin to skin with the mother immediately in the delivery room, and we try to initiate breastfeeding as early as we can. After a baby is delivered and established its breathing, we do daily routine care in the postnatal wards. This is very important because complications can arise on the first 24 hours to 7 days. At King's College Hospital, we do daily rounds for all our postnatal ward babies. This is where we do close observations and daily essential routine care, as well as monitoring and establishing feeding. We work closely, of course, with our obstetric nurses and midwives. And as you probably would have heard, we have a lactation consultant nurse who would actively support these mothers for their breastfeeding needs. Now, we are both a mother-friendly and a baby-friendly hospital, and mothers are given choices as to whether they would want to breastfeed or to have supplemental formula feeds for their babies. As well as feeding and as well as monitoring feeding and weight monitoring. Of course, we do congenital heart disease screening. We do screening for jaundice. We do non-invasive monitoring for jaundice with our transcutaneous bilirubinometer. However, if babies need to be exposed under phototherapy, then we could still also do this in the postnatal wards without separating the mother from the baby. We do regular hearing screen as part of the normal routine newborn care. And as what you have heard from Dr. Ruba, we would do the first immunization in the first 24 hours after birth, which would include BCG and hepatitis B. Included in the daily routine care would be special needs for babies and special requests from parents, such as circumcision, or if there are significant findings in the physical examination, which is done within the first 24 hours, we would try to resolve them. More common problems that we are now seeing in our postnatal wards would be issues related to tongue ties or some talipes or clubfoot, which are addressed with our pediatric surgeons and with our physiotherapists. So that is relatively what we do for our term babies. Now, how about for premature babies? Premature newborns are those who are born between 23 to 37 weeks. The care of premature newborns is a little bit more complicated, and this should usually start even before the baby is born, where we do antenatal counseling and meeting with parents. The same principle would apply with the initial steps in trying to stabilize a baby. However, there are different techniques. For example, if we are thermoregulating a term baby with just a hat and keeping it warm, for preterm babies, especially if they're under 30 weeks, we can use several interventions like using a plastic bag after birth. This simple measure has actually been proven to actually decrease mortality and prevent evaporative water loss. For preterm babies, we do establishment of breathing and airway a little bit differently because due to prematurity, they may not always be able to sustain their own breathing. So we may need to support them with invasive and non-invasive ventilation. We may need to put a little bit of a tube in the mouth that goes to the lungs and attach them to the ventilator. And of course, with these special needs, they are then admitted to a level 3 neonatal intensive care unit, like King's College Hospital's neonatal unit. So this is just a sample of what we do. This is the actual team at work when we do have preterm babies. We are a supportive team and we advocate the golden hour principle of establishing preterm temperature and antibiotic administration within 24 hours, which again has proven to reduce mortality among preterm babies by at least 80%. We do have what we need for thermoregulation. We keep babies in the incubators. We start very early on total parenteral nutrition, which means we administer proteins, vitamins, minerals through a special line that would ensure that these sick and little babies would get what they need in terms of nutrition. Of course, as a neonatal intensive care unit for preterm babies, we do daily assessment and review of their clinical condition, their growth, and their nutrition. We also address very special premature needs, which include regular cranial and head scan monitoring, just to look for or act early on for any early brain bleeds. We are very cautious about eye checks and monitoring needs for retinopathy of prematurity. More importantly, we are advocates of actually not just a multidisciplinary team approach, but more importantly, we do promote and encourage parental involvement. So at King's College Hospital, we also have a rooming-in facility whereby if babies are already ready for discharge or just maybe a week or a few weeks before discharge, we room them in with their parents so as to familiarize them with the management of their newborn, as well as to assess their competencies and their confidence in bringing their little babies at home. The third part of the talk is actually the care of the newborn with maternal COVID-19. As this is a very relevant topic today, I have kind of included very briefly neonatal babies who are suspected for neonatal COVID infection are newborns who are born to mothers, obviously with a history of COVID-19 between 14 days before delivery and 28 days after delivery, or all newborns that are exposed directly to known positive cases, not necessarily their parents, but can include even relatives or medical professionals. Whereas those babies confirmed to have a COVID-19 are those who have been proven to have positive respiratory tract or blood specimen PCR for COVID-19. So just to highlight a few things in terms of the management, apart from the medical management, there are things that we advocate. We do minimize separation of the mother and the baby, even if these issues are actively discussed with the mother if possible, even before delivery, and we allow them to make informed choices. However, in case we would advocate that if both mother and baby are asymptomatic, the recommendation is to minimize separation so they stay in the same room together. Breastfeeding is still recommended, as what you would have heard, that there is very little evidence that COVID-19 is passed through the breast milk. However, if the baby is unwell, then the baby is admitted to the neonatal unit in isolation, and this is one of our team attending to one of our premature babies born to a mother with COVID-19. So those are the three parts that I would like to stress today. However, for all babies who are well for discharge, we do regular newborn follow-ups. That is 2 weeks after discharge, usually by myself, by the neonatologist. And if there are any problems, I see them again around about 4 weeks. And after that, they are seen by regular pediatricians at least once every month or every 3 months thereafter in addition to the regular immunizations. For our preterm babies, we would recommend babies' neurodevelopmental follow-up or neurodevelopmental screening, which can be done at 6 months, a year, and up to 2 years of age. And this is our specialized examination and testing, which is done in cooperation with our physiotherapy team to assess the different levels of development of a baby, different milestones that they need to achieve. And if there are any early problems, then we are able to do targeted management. All premature babies are followed up until 1 to 2 years of age.
Thank you, Doctor. Thank you very much. We're gonna move now to our lactation consultant to talk to you about breastfeeding. Over to you, Helen.
Thank you, everybody. Shall I go ahead now?
Yes, please.
Okay. Just like to say I'm Helen Leslie Stain, sometimes Helen, sometimes Leslie. So in case you hear either names, it's the same person. I recently joined at King's since March, and I've been actually in the UAE since 2008. So I'm so pleased to join the team at King's, and I think what's come across in a lot of the talks is the idea of teamwork, which is absolutely imperative and really it helps in the success of everything. So today I don't have a presentation, I'll just do a talk and then address any questions that will be coming up. So as with most things, the best idea is to have a plan or a goal. So you should have thought a little bit about how you plan to feed your baby. And really, as a lactation consultant and for breastfeeding support or feeding support, it's about what the mums and dads want for their babies. So we are here to assist you with your concerns and any questions. And with the role as a lactation consultant, I will work with you and we will work out the best plan for you. So as mentioned before, during your visits to your doctors during your pregnancy, it would be a good idea to possibly meet up and just have a one-on-one session or talk just to discuss if there's any concerns that you have or any specific questions, because preparation is really helpful. As I've seen and what we know, once the baby comes along, there is such an overwhelming time of emotion and just elation. So that's not really the time to discuss and talk a lot. It's more about us spending time with you and monitoring what your baby does and assist with the feeding in that way. So as even what Dr. Maria mentioned earlier, once the baby is born, we look at doing skin-to-skin time, which is such an important time for the baby to have that direct contact on mom's chest. And this initiates and helps the baby to develop the instinctive responses to feeding. So the baby often crawls on the mom's chest, and they can even lift up their heads and move around and navigate themselves towards the breast, which is like a little bit of a warming up exercise for the baby, where they start to open their mouth really wide and start licking their little lips. And they also move their hands towards their mouth, which then guides them towards the breast. And most often, without us having to do anything, as your babies are so clever, they know exactly what to do, and they will open their mouth beautifully wide and then attach themselves onto mom's breast and start feeding, which is so important to get the whole milk supply process going. Babies, we recommend and we look at making sure that the baby has a feed from the mom within half an hour to an hour after birth. If for any reason the baby has some challenges to make that step and get onto feeding, then we will show you how to do some hand expression and collect some small drops of the colostrum, which is more than enough most of the time for what baby requires. So we leave it at that, and then your baby will go and have a sleep. And many times the babies on the first day would sleep for many hours. But within the hospital setting, we kind of look at around a maximum time of around 3 to 4 hours, where we would try and assist you with getting the baby to feed again. And if for any reason the baby was too sleepy to feed, then again, we can do some hand expression. So this really brings on an important topic, because as to what to expect on the first day of baby's life, which is very different to day 2 and 3 and onwards. So I mentioned that the babies do sleep a lot on the first day, and normally by around the second day, often in the evening, the babies will suddenly become more activated and start to feed a lot more. So don't be worried if your baby is sleepy on the first day. Most of the times, as mom is and dad are all very tired after having gone through the whole birthing process. Baby also feels tired. So the best thing to do is just to keep the baby on your chest if all's well with the baby, as your body will really help to regulate your baby's temperature and help with feeding when the baby starts to feel hungry. So that's what we advise, and we will monitor your baby's temperature and make sure everything is going well. And important to take some rest on that first day. Many times the question comes up, or the response comes up from mums and dads when we're doing the rounds in the mornings or at any time, is saying, our baby was awake the whole night, and baby wouldn't settle down, especially between the hours of around 1 to 5 a.m. And phenomenally, this is actually a natural response, because your baby and your body are still in tune, and the milk producing hormone peaks at this time in the woman's body. So that's around 1 to 5 a.m. And I often see the facial reactions on mums and dads' faces as in, whoa, this is it, this is what's going to happen. Don't worry, we have a solution and we have ways of helping you. So we look at how you can be comfortable, positioned comfortably during this time, where you can actually take some rest while your baby is feeding, and you can be observing your baby and understand that babies do this cluster feeding. So they often feed on and off for a number of hours, and then they might sleep again for 3 or 4 hours after that. So that is very normal behavior in babies. Babies don't always go according to a clock or an app. So it's very important that mums and dads observe their baby's behaviors and observe to see when the baby is hungry. And if we mention that the babies might sleep for a long time on that first day, parents worry that the baby's blood sugars will drop. But understanding that the baby's requirements on the first day is significantly less compared to day 2 and onwards, it helps to understand this. So if you think about it, and most people don't realize that your baby's tummy on the first day is really so tiny and can actually comfortably hold around about 5 to 7 milliliters at a time. So that's looking at 1 to 1.5 teaspoons. So don't have this concept that your baby has to take a large volume, because it often is a fact that parents are worried that the baby isn't having enough milk, or the colostrum, which is the first secretions of fluid that comes from the breast. And sometimes it looks watery, sometimes it looks a little bit milky, and that will change as the day goes on, as the days go on. So what I would always say to parents is, no matter what comes out of the breast, it's absolutely perfect and it's specific for your baby. So just believe in yourselves, believe in your baby, and as I said, we are there as a team to guide you, because there's a lot of information and it's not always easy to comprehend all of that during your stay in the hospital. So as you go home, we will be there to guide you and support you even once you've been discharged. Some of the questions that have come up have been about, or one of the many frequent concerns that parents mention is that it's very painful when the baby is feeding. And again, that is not always the norm. There might be some sensitivity, there might be some discomfort, but if mums are experiencing severe pain throughout the feed, that is a red flag, and that is definitely something you need to let us know about. Often this can be relieved simply by changing the baby's position or helping you to get the baby on more effectively. So if you think about it, when the baby is feeding and there is pain, it's often because they're not latched on deeply enough, so they're more on the nipple. And with breastfeeding, it's about breastfeeding and not nipple feeding. So if you're having pain on the nipple, it's probably that the baby isn't latched deeply enough. And this is often when they're blocking the milk from coming out. As mums will often comment that they don't have enough milk, but 99.9% of the time there is more than enough colostrum available for the baby, and it's a matter of how it's able to move from mum towards her baby. So those are the things that we need to look at. And then, as I said, that the baby's tummy is so small on the first day, or can comfortably hold such a small volume of milk, your baby is not going to pass that much urine on the first day. So sometimes the baby would only have around 2 or 3 wet nappies, and that would be more than enough. And when they start to pass meconium, that's that sticky, tarry, interesting looking poop from the baby, which is another good sign that your baby is actually getting colostrum. And as the colostrum is the most effective substance to help your baby pass stool, it's a natural laxative, better than anything else that could be devised by any person. So again, just believing in yourselves, believing in your baby's ability is so super important. I'm just having a look to see what other questions have come up. Having enough milk supply, again, it takes time for your milk supply to get established. So normally on the first 2 days, there is the colostrum, which is in small volumes. Around second or third day, mums will start to feel some heaviness or fullness in the breast, which is a sign that the next stage of milk production is starting. We're running out of time. All right. Some other sound there. And the breast will start to fill up, and that stage of engorgement or fullness will last around 3 or 4 days. So it's very important during this time, if you're having pain, fullness, and difficulties with feeding, that we assist you in this stage. And then this will settle down, and you will have your milk supply in good volume by around 7 to 10 days. This will be mature milk. And this will keep increasing till around 4 to 6 weeks after the birth of your baby. So that's why it's so important to feed regularly for the first month. Spend a lot of time with your baby in direct contact. Very often we also see that the babies don't settle once they've been put down on their little beds, because they are looking for your warmth and for your smell. That way they know they're safe. So it's important to make sure that your baby is in deep sleep before you try to put them down to sleep in their crib or on their bed, or in their, whatever place you're going to put them to sleep. There's a lot of questions that parents have after the baby has arrived. So we'll be there to continue guiding you through, and we're always available. I'm just trying to see if there's any questions specifically that have come up now. There was one question that came up about harvesting colostrum, and that is collecting some of the colostrum before the baby is born. These are options. Again, this will be case to case, and it depends on any risk factors during your pregnancy, but these are things that we can certainly address and assist you with during your pregnancy and talk about. So again, I really recommend that if you're having your follow-ups, please do let us know where we can arrange to have a time together, just to have a quick chat. And as well, even with the antenatal classes, a lot of these concerns are also discussed. And All right.
Thank you very much.
All right. I can talk and talk and talk and talk. You got to
that's
stop me.
fine. I really like all those information. They're very informative, but I need to stick to the
Absolutely.
timing.
Yes. No, I agree. Thank you.
Um,
Thank you, Rama.
Now we will be moving to our senior midwife, Hannah Duncan. She will tell you a little more about our antenatal and postnatal care provided by King's, as well as she will take you in a virtual tour in our maternity department. Over to you, Hannah.
Hi, thank you, Rama. Hi, everyone. It's lovely to be here today with you all on this online conference. I hope you're all keeping safe and well. So like Rama said, my name is Hannah Duncan. I'm one of the senior midwives at King's. I am a maternity coordinator there, so I coordinate all of maternity. So that being antenatal, intrapartum and postnatal care. So for me, I'm going to talk a little bit about antenatal services that we provide here at King's, and also the postnatal services that we also provide at King's. And this is obviously to support you guys, okay? Because during pregnancy, it can be a really, really tough time. Both mentally and physically, and we want to be there with you every step of the way. And we also need to make sure that your mental health is cared for as well. So that is what we do here. So let me talk to you about the antenatal classes then. So alternative to the antenatal classes, I also do my own sort of antenatal education sessions on Thursday mornings between 9 and 12. And these sessions you can come to see me just to have a little talk about antenatal education, if there was anything additional that you need to know, okay? No questions are silly questions. If you just wanted to come and have a little chat with me, then that's absolutely fine. Obviously, anything medical is run by your consultant, so those things would have to be run past them for verification. But anything in relation to antenatal education, then come and chat to me. So the antenatal classes then, guys, okay, so we run these over a series of 3 sessions. And these are, session 1 is the antenatal period, so all about your baby's development, your baby's growth, and what happens while baby is developing inside you. And then session 2, then we talk about labour and delivery, the juicy content which everyone likes to hear about. It's very, very informative. There's a lot of information. So when you do book onto these classes, and when I am taking these classes, I always tell you to take sort of a pen and paper just to write down anything that you need to clarify, or if there's anything that you need to keep to yourself, okay? And then the 3rd session then is postnatal. Now, postnatal is my background. I've been a midwife for almost 10 years now. Even though I'm trained in every aspect of midwifery and maternity, okay, postnatal is my sort of little baby. So for me, the transition to motherhood is very, very important. Even if it's your first baby, your second baby, your third baby, okay, this transition is massive, okay? And it's massive not only for yourself, but obviously your partners, we can't forget the husbands, and also the wider family members as well, okay? So in the 3rd antenatal class session, I talk about postnatal, how we support you on the ward, like I know Dr. Maria and our lactation consultant Helen touched upon, okay? And how we work as a team collectively in order to provide safe and evidence-based care for you and your baby. And not everyone is different. Every mother postnatally has different things they need support in, okay? So not everyone is the same, and that's why we provide individualized care per person, okay? So that's the antenatal classes. Now, if you want any advice on how to book onto these, Rama will send you all of the information later along with the prices, and then you can send an email to myself, and then I will then disseminate all of the links. Currently, I am in the UK, hoping to get back very, very soon. So at the minute, I'm doing the online antenatal sessions. Even if I was in Dubai, I'd be doing exactly the same due to COVID-19. So this is how we're operating currently. So if you want more information, then please do ask myself or Rama, and we can get all of that relevant information sent over to you. Now, after you've had your baby, then we're not cruel. We don't just send you home and say we'll see you in 6 weeks or 4 weeks with your consultant, okay? Obviously, like I said, the transition is massive. So we need to make sure that we are supporting everyone every step of the way, even from discharge from the hospital. You will be asked if you want to book into the Well and Mum Baby Clinic, okay? Now, this clinic is optional. You don't have to come, obviously, okay? But I run this clinic. Basically, I set this clinic up when I come to Dubai. And obviously, this is to support mums, dads, and family members after you've had your baby. So we check up on mums, we check up on babies, we weigh babies, we check mum top to toe as well as we check babies top to toe. Okay, and we work in partnership with lactation consultant, which is Leslie. So obviously any breastfeeding problems, of course, I can address, but again, Leslie is there for that extra support and more individualized care with her expertise. And obviously then we work in partnership with the pediatricians. So again, booking your child's vaccinations, your baby's vaccinations, okay? Now, the clinic babies can come from birth up to 6 months. So I see babies up to 6 months, again, like I said, in partnership with Dr. Maria, okay, and our wider multidisciplinary teams, okay. I do have, let me just see if I've got any questions here. But if there's anything else you'd like to know about our maternity services, then please do ping an email over to us, and like I said, Rama will give you the email address, and all of those questions and inquiries come through to me, and I'll obviously answer all of your questions and basically navigate you throughout your pregnancy. So even when you first book, okay, I like to get to know women from the beginning all the way through, okay, so I can assist them from the minute you book, from the minute you find out you're pregnant, all the way until you've had your baby. And that's so nice. That continuity of care is obviously what I love, and obviously which makes me want to be a midwife and love the job that I do. So yeah, if you have any questions or queries, then please do ask. Like, let me just have a little look if they've got any questions here for me. I know there's a couple for Helen, but just bear with me 1 second while I go down this long list. Okay. Just bear with me, Ram. I'm just checking these answers and questions. See if there's
Totally
any more.
no problem. I'm here with you. I'm looking at the questions too. So for everyone who
guys, okay, so I'm just going to share my screen now to the virtual tour. So obviously, again, because of COVID-19, unit tours have been suspended for the safety of yourselves and your babies and the general public, okay? So I'm just going to share now a virtual tour that has been put together by the marketing team. And it's going to take you into the delivery suites, and it's going to show you around the rooms. It's also going to show you the pool room as well. I know at the minute, obviously, water births are still suspended, and this is on sort of a day-to-day basis in sort of currents with the local guidelines and the World Health Organization as well, okay? So I'll still show you it just in case everything comes back to normal and you can have your lovely water birth, okay? So I'll show you that. And then also what I will do, I will show you upstairs the postnatal rooms as well on there. And then obviously if you've got any other questions, then of course you can just feel free to ask me, okay? I'm here, all right? So let me just try and share my screen, guys, okay? Let's see. Bear with me. Okay. Okay. I'm just having a problem, Rama. 2 seconds. There we go. Here it is. Okay. So can everyone see that?
Yes.
Yeah.
Perfect.
Okay. Okay, guys. So obviously, as you know, this is the outside of King's College Hospital, which you all come for your antenatal clinics. For those of you who are not King's mums, obviously, and you're interested in King's, obviously this is the outside reception area, okay? Now, I'm just going to go inside, okay? So just bear with us. So, here we have it, guys. Okay, so this then is our labour and delivery rooms. Okay, so this is LDR, known as labour and delivery rooms. So what you will find now, this you will find on the second floor. Okay, so this is on the second floor when you come into the unit. So for those mums who are coming in labour, okay, or query labour, if they need to be triaged for whatever reason, if you think your waters are broken or anything maternity related, okay, then you do come to the second floor, all right, unless told otherwise by your obstetrician. Okay, so this is the unit, like you see there, is one of our obstetricians nurses. Okay, so we've got a team of nurses, obstetricians, midwives that work closely alongside us in LDR, along with the anaesthetist as well. Okay, so I will take you now into the water birth room. Okay, so as you can see, guys, these are the rooms. Okay, they are exactly the same in all 4 delivery rooms, only this one obviously is a little bit different because it has the pool. Okay, now as you can see in front of you, you have your delivery beds. Okay, now these beds are very good, okay, because they can come up, they can sit upright, you can sort of have your legs in different positions. Okay, so you don't have to be lying flat on the bed. All right, so this is very, very good. These beds are quite magic. And then you have the little monitor in every room, obviously, is to monitor your baby. Okay, now some women will be continuously monitored in labour, some won't, and that all depends if you're high risk or low risk. Okay, now this is something that will be told to you by your consultant obstetrician, and have that discussion with you before birth. Okay, so I'm just going to go to the right a little bit, just for you to see the lovely pool. Okay, so this is the birthing pool, guys. Okay, this is basically like a very, very large bath that we fill up. Okay, and it must be of optimum temperature for delivering and birthing. Okay, but when you do have, if your consultant sign you off for a water birth when everything is back to normal, okay, then there is certain things that we will need to go through with you and discuss, you know, the risks, if there was anything high risk that needed to be done while you are in labour, then you would have to come out of the pool and proceed labour and delivery, you know, outside of the water. Okay, now there may be many reasons for this, but obviously, like I said, at King's we are working in partnership with yourselves, and if there was any problems, we would let you know what they are and our rationale for this. Okay, so this is the lovely pool room. As you can see, you can still use the birthing ball, guys, on the sides. Okay, you can go back and forth. Some women don't like to be constantly submerged in water, they like to come back and forth. I mean, it's completely up to you. Okay, so then I'll take you to the bathroom. Okay, so all of these all of the rooms obviously have your own bathroom. Okay, now it has a shower, and like I say, a sink there. Okay, now the shower has got a little seat, because obviously after you've had your baby, you might stand up and have like little jelly legs. Okay, so obviously standing up you may feel a little bit faint, so we do encourage mums to sit down to have a shower post delivery. Okay, and then obviously, as you can see, there's just your toilet. Okay, and I'll move around a little bit more. Okay, so you have your bathrobes, and then your towels there are obviously put there on a daily basis. If you require more towels, then absolutely no problem, we can get them for you. And your amenities are always there as well. Again, if you need additional, we can get those as well. Okay, so I'm just going to come back to the room, because in all rooms, if I move around, you do have your wardrobe. Okay, you have your own fridge underneath. Okay, that is stocked up on a regular basis. Okay, and also you have your TVs in all rooms, so if you want to watch a film, or you know, some people have different coping mechanisms in labour, they have different distractions, they like either loud music, quiet, or some people like to watch films to distract them from the pain. You know, it's completely up to you. So that is there. And also what I will tell you around here is this little chair there also pulls out into a sofa bed. Okay, so these are for your birthing partners, whether it be your husbands, your mum, or your friend, whoever your birthing partner may be. Now, what I will say during the COVID pandemic. Currently, we are only allowing your birthing partner, which would be one. We used to allow 2 birthing partners, but now it's just the one, okay, to be with you during labour. All right. So that's a little bit about the labour rooms. Now I'm just going to go out, back out there, okay, if I can. I'm back in the bathroom now. We don't want to go back in the bathroom. Let's have a little look. Okay. And there we have it, guys. Okay. Now, what I will do, I can send you the link, because then on the link on the website, there's also pictures of the virtual tour of the rooms upstairs on postnatal ward as well, which you can have a little look at. Ram, if you would be so kind to just share these with everyone in this conference, all our mums, just so they can see the rooms upstairs, okay? And
Sure.
obviously, if you've got any questions about the rooms, I mean, it's the same layout, guys, so it's pretty similar, okay? You still have your sofa beds where mums or your friend, whoever's your birthing partner, can stay. And again, just to reiterate, on the ward, it's just birthing partners. It is no visitors currently due to COVID-19. However, hopefully, if you have your delivery, you're out within 2 days, and if you have your cesarean section, usually your time is around about 3 days. You're not that long, and you'll just have to FaceTime for now. But if there's any other questions, then please do feel free to let me know. But it was lovely to chat to you all, and I will hope to see you very, very soon. I'm sure I'll see most of you at some point if I haven't seen most of you already. Yeah, and take care and stay safe.
Thank you very much, Hannah. I will also share with everyone the link to the virtual tour if they would like to go through it themselves, as you said. So expect one email from me early next week, possibly by Sunday, that has all the information that you need to know and you are asking about over here. Now, I would like to share with you a video of the precautions that we are taking in our hospital and medical centers, because we have received questions of a lot of concerned expectant mothers who are concerned to visit our facilities. So I hope this video will help you understand all the precautions that we are taking to make sure that you are safe when you visit any of our facilities. Hannah, can you please stop sharing your screen?
Bear with me, let me just go back. Let me just see. There, done. Okay?
Yes, thank you, Hannah. I will. Okay. All right, that's it. I will ask Dr. Gari to just give a final speech at the end, and then I will be announcing the lucky winners. Over to you, Dr. Gari. Thank you very much.
Thank you very much, Rama. Listen, this has been a one-off. This has been something that we've been looking forward to, an online conference. I mean, you know, 12 years in Dubai, Abu Dhabi, and this is the first, an amazing conference. Thank you for the organizing, for Rama and John Paul. all from our marketing team. My doctors, midwives, lactation consultants, thank you so much. Fantastic engagement. Now, you know, we're here at King's. We're doing everything throughout this time to make sure that it's safe. Rest assured, we will not be doing anything that could put you or your baby at risk. So, you know, thank you for our whole infection control team and medical microbiology team for getting us to where we are. We look forward to welcoming you all at King's. Rama will share through whatever information that you may require by way of email. Look us up, Instagram, Facebook's, we're there. And as I said, it's been a pleasure to spend this day with you, and look forward to meeting. Thank you.
Thank you so much, Dr.
Over
Garin.
to you, Rama.